As we discussed last night, the two main themes of our Shabbos experience is going to be mental health on the one hand and end-of-life issues on the other hand. So this room will be discussing end-of-life issues, one of the important topics for in general what we in general in medicine and Klal Yisrael are facing, and the other room is going to be dealing with some mental health. Some families have chosen to split up and have representatives in each room, but otherwise, hopefully, we will be able to at some point share and exchange some of the information. Here in this room this morning, it's my pleasure to invite Rabbi Glatt, and he'll be talking about some of the topics around triage and end-of-life care, and then we'll have a Q&A, as I said. So we're going to be mindful of the time. We're going to end at around 11 o'clock. The two speakers are aware, and we'll try to figure out exactly how that will work out in the morning. Without further ado, Rabbi Glatt.
So thank you very much, Rav Laser, as always. Beautiful putting together on the fly at the very last moment, so kol hakavod. The learning objectives here will be really to talk about a number of complex end-of-life issues, which you'll hopefully have questions on. And one of the most common questions that I get is, can religion and halacha and medicine coexist? And the answer is absolutely. HaKadosh Baruch Hu created the world. HaKadosh Baruch Hu is the author, the editor, the redactor of everything that we do. So therefore, there cannot be, by definition, there cannot be a conflict between science and halacha. Now, sometimes we have to work at it to figure out what HaKadosh Baruch Hu intended us to figure out. But there, by definition, cannot be a conflict. And I always like to tell people that all of these seeming conflicts, well, the Gemara says this and that's ridiculous, sometimes we have to have a little humility, because one of my favorite examples of this is a Gemara that talks about how certain types of genetics are only transmitted on the female side. And there didn't seem to be any explanation of that. And the Gemara says, no, this is only transmitted to the girl children and not to the boy children. That doesn't make sense. The other way around, science understood, but we didn't understand how something could be transmitted only to the girl children. And we laughed at the Gemara, not me, but people laughed at the Gemara and said, what do they know? And then, of course, when we learned about mitochondrial DNA being a component of the mother's egg that isn't DNA from the nucleus, all of a sudden we understood that the Gemara was right and science just didn't know. So there are many times that we have seeming conflicts between what science tells us and what halacha, what Gemara, what Masorah tells us. And before we say that one is wrong, meaning that the halacha is wrong, that our Masorah is wrong, we should have a little bit of humility and say that maybe science doesn't yet fully understand everything. And that's a good introduction to end of life, because end of life is always changing. There are many, many different aspects of end of life that seem to, the mores, the ethics of the world, don't necessarily agree with the halacha. At least secular mores and ethics don't seem to follow sometimes halacha. And the most common shilas I get from doctors are, they want me to do this. Am I allowed to do this? What should I do in this situation? We do training of doctors. We have a Shomer Shabbos residency, for example. And there are shilas that come up all the time. And an educated consumer is the only way that you can be a Shomer Torah Mitzvahs doctor. You have to know what the halacha is, and you have to know to ask shilas. Aseh l'chorav, in my opinion, is the single most important imperative for a Jewish doctor. A person has to have somebody they can ask shilas to. A person has to know what is a shilah, what's not a shilah. Sometimes doctors, if they don't have a sound foundation in halacha, so they don't even know that this is a shilah. What's wrong with doing this? And they don't realize that it could be ritzicha, it could be actual murder, albeit their hearts are in the right places, but if they're doing something that is usur, they're doing something that is usur. So it's critically important, in fact, that they do exist, and I don't have any problems ever with anything that I've read in the Gemara, anything that we have in our Masorah that seems to be contradicted by science. And that includes the common buzz issues like evolution and ontology and phylogeny and all the things that we sometimes try to shy away from in yeshivas, because sometimes the Rabbeim aren't given the adequate scientific and halachic background, and they just like to shy away from stuff and say, no, just ignore all that science stuff. And that ultimately, I think, is a tremendous problem, because when kids grow up, they're no longer going to accept that, well, that's what the Torah says, and that's what science says, and science is wrong. And I think as the children grow up and they question if we don't have the answers for them, so that's far worse than us saying to the children, this is a problem, and this is how the Torah addresses it. So a lot of the end-of-life stuff is based upon the principle of primum non nocere, which is a famous Latin term. I once gave an entire secular talk about the origins of this. It's an interesting discussion where these words were first discussed and used, but that's the bottom line. A physician, by definition, his job is to make patients as best as possible. That doesn't mean to cure them. It doesn't mean to always extend their life to 120. Halavai, that's what we should be able to do. Everybody wants to have a healthy, long life, fully capable, without mental or physical deterioration. A good physician tries to do that to the best of their ability. But we understand our limitations. And the job of a physician is to make the patient at all times as comfortable and as healthy and as, I would say, halachically capable as possible. Rav Shechter Shlita always gave us the example that he would say, what happens if an 18-year-old kid who's a very, very star athlete, Rahman al-Islam, gets into a car accident, he actually used the term a skiing accident, and they tell him he needs to have both of his legs amputated. He has terrible trauma. There's nothing that they could do with reconstruction. He needs to have both of his legs amputated. The kid's alert, oriented, says, nah, if I can't ski, if I can't be a professional basketball player, if I can't be vigorous and athletic, I'd rather die. I forbid you to do the surgery on me. So what's the halacha? So in the time of a base, in the time of a Sanhedrin, they'd strap the kid down, give him anesthesia, and take off his legs because it's pikuach nefashos. He'll live a perfectly happy, healthy life. Just his legs are going to kill him right now because Nebuch, he's had a terrible traumatic incident. But his life is not impacted by that if you do the surgery. If you do what you're supposed to do, the halacha requires a person to save life when the parameters of that saving life fit within the halachic framework. Somebody to lose their legs, Rahman al-Islam, a terrible, terrible, terrible thing, but halacha would say that that person is a absolute chiyuv to go and preserve their life. That's one extreme. The other extreme, which unfortunately I also get many shilas about, is you have a person who has terrible, Rahman al-Islam, lo aleinu, metastatic cancer all over the body, is in terrible pain, and I had such a maisa that it still hurts me very much. The family came crying to me, literally crying to me, that the patient was suffering. He was in agony. And the Rav that they'd asked the shaila to had said, no, you're obligated to continue to give them fluids. You're obligated to continue to do everything for this patient. The patient had zero medical expectation of having any likelihood of outcome other than death. Nebuch, our skills are quite limited. We all know that. We don't like to tell that to the public, but we know that our skills are sometimes quite limited. And there was absolutely nothing medicine had to offer this person other than that we could keep that person alive in pain for an extra few days. And the person that they'd asked, a very, very bright Talmid Chacham who, knows 99% of the halachos much better than 99% of the people in the world, did not really understand medicine. And Paskin that, you have to give this patient fluids. So they came crying to me. I said, number one, fluids aren't indicated in this patient. You're actually fluid overloading the patient. That's why they're having anasarca, and that's why they're nebuch in such pain, because they were being basically given pain-giving medicine rather than pain relief medicine. The fluids were contraindicated. So that was number one. So there's no chiyuv to give somebody hydration in a situation where the hydration is actually killing them or certainly not helping them. And second of all, this patient was in severe pain that wasn't able to be controlled with appropriate palliative methods. So there is absolutely chiyuv, and the great poskim talk about this, that there is no chiyuv in that situation to prolong death as opposed to prolonging life. And Lanias Dati, that patient was having a huge disfavor done to them by insisting that everything be done. The patient was actually going to be fully coded. That patient was going to be intubated. And I think, Baruch Hashem, I had the ability to step in, and the patient did not have any of those interventions. And I think that this is one of the most critical ideas that we have. And we as physicians are supposed to make people better, spiritually better, physically better, and that doesn't always mean to give them more therapies. And that's triage and end of life. We have to decide what is appropriate medically first, and then does the halacha sanction sometimes halacha allows. There's three possible answers. Halacha says it's mandated. Halacha says it's awesome. Those are the two extremes. Those are sometimes the easiest cases. The gray area in between is where most of the discussion comes, where there are valid differences amongst the great poskim who do understand these issues. I've had the wonderful zechus to speak with some poskim that I'm embarrassed to say sometimes they knew medicine better than I did. They knew the intricacies. I once was discussing with a great gadol a complex obstetrical shaila, and I was amazed how much obstetrics this posek understood and knew. And I'll tell you another time, I was asked to give my opinion to a gadol b'Yisrael on Zika. And I spoke to him, and he said, well, there is a shaila, and he posed it to me as a medical question. I said, oh, I can give you the answer on that. It was a medical question. He says, I wasn't asking you for the medical answer. I was saying that medicine doesn't know the answer to this question. So I was going to give him my opinion. And I said, whoa, he's Yodea Sefer, not only the Svarim that you expect in a base medrash, but he was very, very familiar with the medicine. So those type of poskim, those type of rabbanim, which Baruch Hashem there are plenty of, they're the ones that need to have these shaylas asked to. Because sometimes the default position by many is, do everything. You can't sign a DNR. There are rabbanim out there that say you can't sign a DNR. That's just Keneged HaTorah. That's Keneged the great poskim. So there are, unfortunately, rabbis out there that believe in physician-assisted suicide. You know, they believe that, yeah, well, we have to do mercy killings. We have to do what the patient really wants. And that's also Keneged Halacha. So extremes are very important to be aware of. And that common ground in the middle is critically important to find out where we should be. So I love this slide on the Lubavitcher Rebbe. The Lubavitcher Rebbe Zatzal never liked to refer to hospitals as a base cholim. He called them a base refuah. And that's the way we should view our hospitals. They're a place of healing. Sometimes patients go there to die. But they should always be in a healing, comforting fashion and manner. It's critically important that hospitals be utilized properly. And I just had the zchus to send somebody home from the hospital who subsequently passed away. And they died at home without the PEG, the potential intubation, because they hadn't signed the DNR, and the central line that was about to be put in, when I knew medically that there was zero chance that that would make any difference in that person's outcome. There are some times that we have to understand that we are quite limited in our abilities to make a patient better. And because we can do something, yes, we can put in a central line, we can give them vancomycin and Zosyn. We can go and put them on whatever drug du jour we want to give them. This patient could have been on 5 pressors. It wouldn't have made one iota of a difference. Their time, Nebuch, was up. And what we have to do in those situations is make sure that we do what is best for that patient and not what is best from our point of view, what we think should be done because I can do it. And that's why they have to be a beit cholim. They have to be a beit refuah. Not a beit cholim, they have to be a beit refuah. Okay, so I won't go through some of these slides right now, but we make a lot of poor choices, okay? We make poor choices sometimes. And the point of triage, the point of understanding end of life, is to know what is a good choice, what is a bad choice. And not everybody's choices are going to be the same. I always try to discuss with patients and the families, what do they want? Ideally, what does the patient want? These are conversations that the family should be aware of what the patient wants. That is critically important. There is a tremendous gray area in halacha. And Rav Shech the Shlita has written a lot about this, and I've discussed this with him many times. The patient has the authority, halachically, to decide some of these issues. Again, the 18-year-old boy in the example that I gave you with the traumatic injury does not have a halachic right to say, I don't want any treatment, let me die. That's not a halachic right. You have life. We have an obligation. We have an obligation to continuously try and maintain our health, to allow us to serve HaKadosh Baruch Hu. That's our raison d'etre. That's the purpose. It's a little French for my Canadian friends. That is the reason that we live, to serve HaKadosh Baruch Hu. and not to go and have an extra plate of cholent, and not to go to the movies, and not to go and go to the ball game. It's to serve HaKadosh Baruch Hu. And if a person has the ability to serve HaKadosh Baruch Hu, then everything should be done to allow that person to continue. Our definition of quality of life is quite different than the definition the secular society has of quality of life. So that's critically important for us to understand that our choices are going to depend on what that person sometimes wants, in addition to the way that we view, the halacha. And again, different poskim will have different opinions. Rabbi Yashiv was a very, very big kanoi on, even if the patient is suffering under certain situations, you have to do certain things to them. So if somebody's a Talmud, I once had a person that we were taking care of who was a Talmud of Rabbi Yashiv. So we followed Rabbi Yashiv's psak for that person. Somebody else is a Talmud of Rav Moshe, so there's a different approach. My Rebbeim follow the approach of Rav Moshe Feinstein Zatzal, who has written extensively in the Igros Moshe and many other places as to his approach towards end of life. And it's critically important, asay l'cha rav, you as the doctor has to have a rav that you can discuss shilas with, and patients should have a rav. And that rav should be the community rav that knows them. The shilas that are asked to a rav are often dependent upon who the person is. You ask a shaila, a nice simple question, is the chicken kosher, is the chicken not kosher? Well, it sounds like it's straight out. Just look at Shulchan Aruch, what is it possible? And the answer is no. Is the person a rich person? Is the person a poor person? It makes a difference. A rich person, the shaila is no, the chicken's not kosher. A poor person, sometimes, not always, the shaila is the chicken is kosher. You're allowed to take into account their financial status sometimes. You're allowed to take into account shalom bayis issues in regards to a shaila. Should you or should you not take this medication on Shabbos? Should you or should you not be machmir on this hilchos nida question? Well, if that's going to cause a total staring of the shalom bayis in that family, if this is a chronic problem and every time the woman is incapable of going to the mikveh because of some bleeding, so then that's a different shaila than a woman who once time had a question and it's a suffix, yes or no, and you want to be machmir for that woman on the one-time basis. You may be making for that same exact shaila in a different situation where it's debach, it's staring their shalom bayis. So that's why a rav has to be involved. I just was quoted recently in the Jewish Action, the Orthodox Union newspaper, about ChatGPT and its impact on psak halacha. And this was one of the critical issues that I said that I think at this point in time, at least, ChatGPT is not going to replace Rabbanim. And that is because the Rav has to take into account the entire picture. ChatGPT can take into account every written tshuva. But ChatGPT, at least at this point in time, cannot assess the family situation. No, there's a shalom bayis concern here, that there is a parnasa concern over here, that there are psychological concerns over here, that there are other factors over here that a Rav, an empathetic Rav, a Rav with common sense, a Rav who is a true Rav, who provides a tremendous amount of pastoral care in addition to halachic knowledge, so he has to take into account all of those factors. ChatGPT ain't taking that away so fast. Other areas, beware. But at least I don't think a Rav to Paskin is yet at risk. Now these are general ideas that I like to tell everybody, because these are coming up when we teach people in terms of triage, in terms of how we approach end of life. I think it's critically important that we have respect for everybody. That's respect for our Muslim patients, for our Catholic patients, our Protestant patients, et cetera, et cetera, et cetera. And for our, unfortunately, not yet Shomer Torah Mitzvahs patients, and certainly for patients that are, quote, to our right, right? We're always in the middle, right? There's nobody in this room that isn't in the middle. Everybody's either to the right of you or to the left of you. If I was giving this lecture, this shir, in a different room where people were wearing no yarmulkes or everybody in a kapot and a black hat, they would say the same exact thing. We're in the middle. You guys are off to the left, or you guys are off to the right. So everybody has a centrist position. But we know that there are different positions. And the critical factor in being a good doctor is that you respect whatever your patient is doing. I've had the zuchus, I'll call it the zuchus, to take care of patients that have done many, many things that we would not consider normal part of life as an infectious disease doctor. And patients do all sorts of averis, patients do all sorts of activities that aren't healthy, medically, halachically, and I respect every one of them. And I treat every one of them as a human being, because that's what HaKadosh Baruch Hu wants. Everybody has the tzelem Elokim. Some it's a little bit tarnished, but everybody has the tzelem Elokim. And Rav Shachta Shlita always says that you have to treat every person with tremendous respect. And that includes other colleagues, and it includes all patients. And you treat them with compassion. However, at the same time, we never compromise our beliefs. We never compromise halacha. If a patient says, "I'd like you to pull the plug," I've had enough. I'm 60 years old. I can't golf anymore, and that means I don't want to have a tube in me, even though they're healthy, alert, and oriented. I don't want to undergo this procedure. It's a risk, and I don't want to. So you have to not do anything that halacha says you're not allowed to do. This is one of the commonest shilas that I get from residents and younger doctors. I'm involved in a terminal weaning. A terminal weaning is the very, very nice way we say we're involved in killing a patient. And I hate to use these terms, but it's important because we cloud certain very delicate halachic situations by giving them, euphemisms that are pleasant. A mercy killing. You should die with dignity. You should, be allowed to go the way you want. Well, these are often kineged halacha. So we have to know the right terms. A terminal wean is saying we're going to pull this plug on this person and allow them to die when they are not allowed in halacha to have that plug removed without having that intubation removed from them. So is a resident allowed to write the orders to extubate? Is a resident allowed to be involved in prescribing medications that will cause the terminal death? So the answer to all of these questions is absolutely not. So we have to know. So never compromise what you think is halachically wrong or what you think shouldn't be done. So you can disagree with your patients, but at the same time, we shouldn't be fighting with patients, and we should respect what they want. It's not our job to make every single patient that we see follow the halacha. Where you have that opportunity, I'm often asked the question, "Rabbi, what would you do?" after I had the conversation with them as a doctor. And then I tell them, this is what I think the halacha says. Ask your posek. If you want me to be your posek, I'll be happy to do so. Sometimes they have their own posek, sometimes they don't. Sometimes they'll have their rabbi speak with me, and I'm always happy to do that. I think it's critically important that rabbanim speak with the doctors. And I always like to tell this story as well, that, on Friday night in our shul, everybody comes up to, not everybody, a lot of people come up to, say good Shabbos to the rabbi. And I often get shilas at that point in time because it's a quick shilah. And one of the most frequent questions I get is, "Rabbi, am I allowed to take this medication on Shabbos?" So I always ask them, who are you asking? Are you asking Rabbi Glatt or Dr. Glatt? Because invariably it's an antibiotic. That's because the other stuff is chronic. They're not asking me on Friday night, but they just got they just had bronchitis. They saw the doctor today, and now they're giving their Augmentin or whatever it is that they're giving, and they asked me, "Am I allowed to take this on Shabbos?" So I said, "It depends who you're asking. If you're asking Rabbi Glatt, so Rabbi Glatt will say, if that's what your doctor recommends, it's heter gomer to take it on Shabbos." I said, if you're asking Dr. Glatt, he says it's unnecessary to take that antibiotic, and therefore you can't take it on Tuesday, never mind taking it on Shabbos. So I asked them, who are you asking? So the Rav should be speaking with the doctor. These are extremely complex situations. The game of telephone we used to play as kids, you tell the person in the ear, they tell the next person. The two words at the end of that conversation are far apart. The family's understanding of what the doctor told them then is transmitted to the person who's going to speak to the Rav. As great as the Rav may be, they're going to the Rash Bahag, they're going to the Gadol Adar, he's getting faulty information. And you wonder why the psak isn't right. He was given the wrong information. And sometimes they come to me with the psak of the Rav. I said, there's no way this Rav could have said this. It's just impossible for the Rav to have said that, because I know that Rav, or I know the psak halacha that Rav provides. I said, it's just wrong. Now, call up the Rav and say, did you say this? He said, yes. I said, did you know these are the circumstances? He said, no. So, okay, then my psak is different. So this is critically important. Rabbanim should speak with the doctors. The best person to speak with is there's a doctor in the family that's involved with the nebuch, the sick parent, the sick grandparent. That's the person that should be asking the shaila to the Rav, whether they're a man or a woman. The man is the one that usually asks the Rav the shaila. Okay, but his wife is the doctor, and he's was a businessman, so he has a kesher with the Rav, and he goes to the Rav and misses up on some of the medical information because he doesn't understand the difference between this and that, so he thinks they're all the same. So the Rav then gets a misunderstanding of what's going on and doesn't poskin incorrectly. He poskins 100% correctly for the circumstances that were given to him. But those are unfortunately not the real circumstances. So we have to be very careful about these types of problems. So what's the definition of swimming? Not drowning. And very frequently, these are issues that do come up that people, unfortunately, don't know what to do. And that's why it's so important to try to figure out these things before the person is in that matzah. I unfortunately get these shilas almost every day. Somebody just had a massive stroke. Somebody just had a massive medical emergency, and now what should we do? So my approach in general to these things is, in an emergency situation, you probably should do everything, because we're, again, very, very arrogant sometimes. Oh, this person has 2 days to live. That's never, ever come true. Doctors are terrible, terrible in short-term acute prognostication. We get it wrong all the time. I think it's probably better off flipping a coin. Now, we can say the person's an extremist. We can say this person is very, very sick. We can say that in general, people like this don't do well. But somebody comes in with a massive cerebral bleed, so some of those patients walk out of the hospital. To say day one, DNR, DNI, don't do anything, let them die while you're butchering them, I don't think halachically is right. But this is now week 6, and they haven't never gotten any better from the coma. Now you're talking about, what should we do? Should we be giving aggressive antibiotics every time they get a fever? Should we be doing huge diagnostic workups? So then that's a different shaila. So taking into account the time is, I think, a critical factor in the triage of these patients. And the biggest question is knowing when to let go. It's the most difficult thing to do. It's the most difficult thing to do. People love their loved ones, and they want them so badly to stay with them. And they want them so much to go back to the way that it was. All of us have been in this situation, and I hate to surprise anybody, be a spoiler, we are all going to be on that end of that question one day. At 120, hopefully, I always tell my wife I want to die 120 after I gave the Daf Yomi shir, played basketball, and hit my head on the hoop dunking. That's how I want to go. It doesn't work out that way. But we have to be prepared, Nebuch, for that. And therefore, it's critically important to know, when do we want to say, I don't think halacha sanctions or requires further aggressive therapy, and then what does the patient want? There are those patients that say, I would rather have Yisurim in this world and not have Yisurim in the world to come. And I'd rather go through painful treatments and prolonged life, and that is a halachically valid approach if that's what the patient wants. And there are other patients that say, I don't want the Yisurim and I don't want the schar for them, right? I'd rather not be in pain. I'd rather not suffer. Okay, I'll have to deal with that in the world to come. What HaKadosh Baruch Hu is going to do for me because he didn't get the Yisurim in this world. But that's also a halachically valid approach, and I would dare say that's the more commonly paskin halachic approach amongst the great poskim. And therefore, we have to know what we want to do under what situations. And what factors should we take into account in that? So there are many, many factors that need to be taken into account. And the most critical one that is sometimes neglected is pain and suffering. An individual, Rav Shechter brings down the Rav Yaakov Emden and others that hold that the person has a right to say, I don't want these things to be done for me if they cause significant pain and suffering. Again, not in the 18-year-old. You have to always keep that in mind. When the person has a terminal illness, in Nebuch, we don't have anything to offer for them. If the person has a situation where they, unfortunately, are going to die no matter what medicine does, and we're dealing here with, is it going to be a couple of weeks earlier, a couple of weeks later, even a couple of months earlier, a couple of months later. But during that period of time, they're going to have significant discomfort, pain, suffering, other factors. They have, to a certain extent, according to most poskim, according to the poskim that I follow, the patient has the right to make certain decisions in that situation for themselves. And Reuven may decide differently than Sarah, and that's okay. Each person can say, this I'm willing to take, that I'm not willing to take. So there are a number of factors over here, but we're running a little bit late, so I'm just going to go through some of these slides real quickly, and maybe I'll even end over here with this slide, and talk about why did HaKadosh Baruch Hu create illness? It's a very good question. Originally, at the time of Adam and Rishon, there was no illness. How did people die? Sneezing. Everybody knows that. And it's so interesting. I had an anthropologist teacher that once said, in every single culture, Jewish, non-Jewish, in the most remote areas of, we have people here from Australia, so in the most remote areas of Australia, in South America, every ethnic group has something like salud or gesundheit if the person sneezes. Why is that? Because it's in our DNA. It's in our history. That it used to be that the neshama would leave the person's body with a sneeze. And until the time of Yaakov Avinu, when Yaakov said it's not good for a person to die suddenly. We have stories, Avraham Avinu said it's not good for a person to die looking young. You don't get proper covered. You have a little gray in your beard, people start standing up for you when you walk in the room. So if I make the beard black, who's going to know to stand up for me, right? So therefore, Avraham Avinu said it's not good for people not to get older looking. So HaKadosh Baruch Hu said, Yasher Koyach, and we'll start with you. And it says that Avram was the first person that became a Zaken. And Yaakov Avinu said, it's not good for a person to die with sneezing, to die suddenly. And why is that? Because they can't take care of their affairs at the end of life. If you're walking around and suddenly, shoo, and that's it. They call the Chayvra Kadisha. So what about the outstanding financial debts that you had? I owed Reuven money, Shimon owes me money. You want to take care of all that for your children. You want to make sure that everybody is going to have an opportunity to say, I'm very sorry for what I did to you. To accept mechila. I accept your apology to me. To put life in order. To give tzavos to the children. Listen, I don't want you two fighting. It's bad enough you fight when I'm around. If you fight when I'm not around, there's not going to be somebody to mediate. There's not going to be somebody to make sure that there's shalom in the family. And et cetera, et cetera, et cetera. And I would spend an entire shir just on this subject alone, but I want to end on this idea that it is critically important that we use the time of Misa the way HaKadosh Baruch Hu said. Yaakov Avinu said, not good to die suddenly, it's good to be sick before you die. And Hashem said, Yasher Koyach, that's a great idea, and we're going to start with you. And it says that Yaakov Avinu was the first person to get sick. And that's why Yosef and Ephraim and Menashe, they came to visit him, and the whole Ma'aseh, Simcha Elokim K'Ephraim Menashe, that's where it all comes from. Because Yaakov Avinu saw that it's a tremendous, the Gemara uses the term Rachmana. HaKadosh Baruch Hu is referred to as the merciful one in that situation, because it's actually merciful that we get sick. None of us want to get sick, but it's actually a chesed that HaKadosh Baruch Hu does with us to give us a chance to put our affairs in order. And if we, so to say, blow it, if we don't use that opportunity, so then all you do is have the sickness and all the suffering without the benefits that HaKadosh Baruch Hu put into people getting sick. So I'll conclude over here. I have many more slides. They're in the slide decks if people want to look at them, where I really go through a lot of the specific therapies. Do you not have to intubate? Do you not have to do CPR? Do you not have to take antibiotics? Do you not have to take dialysis? And you could go through the triage of every single one of these, but there's a simple overriding halachic discussion about each of them that needs to be discussed. Not everybody needs to die with a peg. Not every single person needs to die without having a DNR or a DNI written down to them. You don't have to die having a central line, a peg, intubation, and CPR done on you. That's not what the Torah requires. At the same time, for some people, that is the way that you're supposed to die. So these are all discussions, and extremely important halachic discussions, but just as important, they're family discussions that people need to have, and people need to express to their children, express to their spouses how they would wish their end-of-life time to be, to make it as benign, if that's the right word, to make it as comfortable, to make it as halachically correct as possible. So I'll take questions at this point in time. Yeah.
One thing to mention is that DNR, in a practical sense in Canada, means that if it's written on the chart, a person comes into the hospital, they are ignored by the nurses. There's no treatment, not even, not talking about palliative, but even regular, expected, decent, caring treatment. And that's it, the person doesn't.
So that's a very important point. For those who weren't able to hear the first part of the question, so DNR, I always say, does not mean do not treat. The R doesn't stand for RX. DNR means do not resuscitate. It is a very specific thing not to do. Do not do chest compressions on me if my heart stops. And we stress in our hospital, and I hope that everybody stresses, that a DNR means just that. And we allow and insist that everything up to the DNR be done k'das v'chedin. And that, yes, if they want aggressive pressor therapy, they'll get aggressive pressor therapy. We'll put these people on 5 presses, but we won't do CPR if their heart stops. We'll give them full spectrum, broad spectrum antibiotics to treat an infection, even though if they die of sepsis, we're not going to do CPR on them. So DNR does not mean do not treat. It means do not resuscitate. The R is critical there. And the same thing with DNI, do not intubate. It means that you still give them BiPAP, you give them full respiratory support, you give them high flow oxygen, you give them morphine to make their breathing better. I won't put a tube down you. That's what that means. But everything up to that, if that is what the family wants, if that's what the halacha requires, needs to be done. So these are critically important. And I know people say what you're saying, and it may be true in some situations, but it certainly shouldn't be true, because that's not what DNR means. And the nurses in my hospital certainly understand that. And I think in most hospitals, I can't speak about Canada, I don't know, but in the areas that I have worked in, DNR never meant, at least not nowadays, do not treat. And it needs to be stressed to the families that you have to follow up with the nurses. If you see that things aren't being done the way you want them to, if they're hands-off approach because you wrote a DNR, so then that's wrong. You have to sit down with the doctors, you have to sit down with the nursing staff and say, hey, we didn't say do not treat. We want everything done up to this point. And that's true for every intervention. We want everything done, but we're not going to go on dialysis. That's a very common shaila that comes up. The kidneys are failing. The person's going to die eventually if you don't go on dialysis, but it's not a guarantee at this point that they need dialysis right now. The family doesn't want dialysis. Or they started dialysis and now they want to stop dialysis. So halacha allows each dialysis to be a separate entity. As opposed to intubation, there'll be a share on this, whether there's any way to not continue intubation, but the simple understanding, the way we have it right now, is that once you're intubated, you cannot stop that intubation. You're not allowed to ever pull the plug. Whereas dialysis, each treatment is a separate treatment. So they're going on Monday, Wednesday, Friday for dialysis. So Monday you said yes, Wednesday you said yes, Friday we said no, we don't want it. That's allowed. That's not called withdrawing care. That's called not starting a new episode of care. So there are differences between pressors, antibiotics, dialysis, and many other situations where each one is a separate event. Same thing with a PEG. You put in a PEG and you're giving tube feedings. It's not also to stop the tube feedings. That's not the same thing as a terminal wean. That's not the same thing as extubating somebody. It's saying, I'm not going to put in the next bag of food. Just because you have a PEG doesn't mean you're mechuyev to use it. And maybe, yes, for 3 months, 3 years, we chose to use it. And now, because the situation has changed, we're not going to continue that form of feeding, that form of hydration. So these are shilas that are complex and need to be discussed with the rabbi as well as the physician.
Let's take your question about intubation and extubation. You got someone on a ventilator tube doing well on 30% oxygen, whatever, desats. Is increasing to 40% a new intervention like a new dialysis?
You're on a certain level of oxygen on the respirator, and the person is now needing more oxygen. Are you obligated, because they're on a respirator, to increase that? And the post can say no. The post can say you're not allowed to decrease the oxygen level. So say that's essentially the equivalent of a terminal wean, according to many posts. Not all, again, not all. There are those posts that say you're allowed to decrease the oxygenation. However, I've discussed it with Shechter Shlita, and I know the opinions of many other great Gedolim. So there are Gedolim that say you can't decrease the oxygen. There are great Gedolim that say you're allowed to decrease the oxygen. So I follow the psak of Rav Shechter in this situation. He was the one I discussed this with initially, and I don't allow them to decrease the oxygenation. However, from a medical point of view, if they were on 80%, and medically we say they're acceptable to go down to 60%, and we lower it to 60%, and they do fine, and then 2 days later they don't do fine, and we would normally bump it up to 80, now you're not mechuyev to go back to 80. And that's a psak from Rav Vosner and Rav Shlomo Zalman. That was a big discussion a number of years ago. So there are different opinions on this. Every person has to go and follow their Rav. But there's a difference between lowering oxygen and removing the tube. According to some, according to others, there is no difference. But everybody would agree in that situation, you're not mechuyev to raise the oxygen up if that is not what the halacha and the family want in that situation.
Said rather strongly, never compromise your beliefs. That sounds pretty strong. What if you are dealing with a patient who's a J witness, who really does not want blood products, and if they don't get blood products, they're going to die? the doctor, of course, has different beliefs.
Well, for the people that will not take blood products. So I'm not getting into the legal parameters. In some jurisdictions in the United States, if they're under the age of 18, they will take that case to court, force the under 18 child to get a blood transfusion, and then give the child back to the parents. I'm not going to get involved in the legal issues. You're not compromising your halachic or ethical position by following the family and not doing something. I'm not mechuyev to walk into every patient's room and say, I disagree with the care that you're getting or that you want, and I'm going to give you this treatment no matter what. That's illegal. You can't do that. I express my opinion to the family. I think you should be getting blood products. You're bleeding out. You've had a traumatic accident. You have a medical problem that would normally 100% of the physicians would give you blood products. And they say, no, I don't want to take blood products. Assuming they're an adult, assuming there are no legal options or considerations to do. So then we follow that person's viewpoint, at least in the United States. Now, I'm not talking about the times of a Beis Din and a Sanhedrin where things would be different. I'm talking about practically in the Eretz Yisrael or in the United States or in Canada. You can't go against the patient's wishes if they want that. But that's not compromising your views. You're not doing something. They're not letting you do what you would like to do, as opposed to, I'm going to extubate you. I'm consciously doing something that goes against what I think is halachically correct. That you're not allowed to do. So there's a big difference between shevi al taseh and taseh and doing. So I could not go and extubate that person because that's what the family wants. But I'm not mechuyev to intubate them, even though I think halacha would say that they should be intubated if the family's not letting me intubate them. So that's not going against they're just not letting me do what I would like to do. That's okay. With the exception of my wife, nobody else lets me do what I want to do all the time. Yes?
Well, I have two questions. I still don't exactly understand the difference between what you explained in the beginning about giving fluids and not giving somebody fluids and doing what they call a terminal wean on a ventilator. I still don't understand. One case you're deciding one thing, the other case you're deciding against it. But the other thing I think a lot of yeah. Okay.
Withholding a therapy versus stopping something that is already in existence. That's a critical factor in halacha. In secular ethics, and incidentally, I worked at Catholic hospitals all my life, this is their opinion, it's not our opinion. They don't always distinguish between withholding and stopping something. So in Catholic tradition or in secular ethics, they don't make such a distinction. They say, well, if you wouldn't intubate them, you're allowed to extubate them. Halacha disagrees with that. Halacha says you're not mechuyev to intubate every single person. But once somebody's intubated, if you remove that tube, so then you have essentially killed them. Now, you may have killed a person who was a goses. You may have killed a person that was terminally ill. Technically, you wouldn't get misas beis din for that, even if you got hasra, and you were warned, and you said, I'm doing it anyway, because the person technically doesn't meet misas beis din qualifications. But you're still a rotzeach, maybe with a good heart. And how HaKadosh Baruch Hu is going to judge you is not my issue, but I can only tell you what the halacha is. The halacha says you're not allowed to go and do that. Whereas, not putting in the tube, you're not a rotzeach. Halacha says you don't have to put in the tube. So that's a critical factor in halacha. Stopping an already existing therapy versus not doing that therapy in the first place. Halacha makes a huge distinction between those two. And therefore, to stop somebody from giving them fluids, so if it's medically contraindicated, of course you stop it. But if it's not medically contraindicated, you let the bag run out, you're not mechuyev to put in the next bag of fluids. That's a new action. That's not called stopping fluids. It's not starting a new bag of fluids. That's a different halachic approach than saying, I'm going to stop the presses they're on. So when we halachically, I tell patients, you're not mechuyev to continue to give presses. So I say, let the bag run out that's running in, and just don't put in another bag. And that is halachically acceptable where it's halachically acceptable. Whereas to stop this, to turn off the presses that are going in, and that's going to cause that patient to die, those presses are giving them the circulatory support that they need, and I turn off that switch, I plug that IV, and suddenly the patient's going to drop their blood pressure, then I have actively killed that patient. But to not put the next bag in, halacha allows that.
My second question is, I think a lot of the controversies that I've encountered has to do with, and their opinion I respect, it has to do with interaction with nursing staff, especially in the ICU. Nursing staff is with patients, 24/7. Doctors are not in with patients 24/7. Often the family's not with the patient, and they often have a distinct view in terms of what their treatment is, what they're asked to do, etc. And especially where I treat, they have great influence. Maybe they should, maybe they shouldn't, but I don't know how you deal with when you say, well, I think we have to continue the treatment maybe because of what you're saying, and maybe what the family is saying, and what they're saying because they're intimately involved with the patient.
I'll flippantly answer your question, and I'll tell you the real answer. The flippant answer is a box of donuts. The best thing that you can do to make sure that the nurses take care of your loved ones is to bring them food. A box of donuts, Pop-Ems. This way they're individual, they take a little one, they're all on diets, so give them a little one.
Nurses in our hospital won't be buying off by donuts, let me tell you.
Well, what I'm saying is to maintain a very good relationship with the nurses and to recognize the tremendous hard work that they do. So that's the easy, flippant answer. The real answer is, yes, you have to do that, but the nurses have to understand that it's not within their purview of what they're entitled to do or not do to make those types of decisions. And those are only decisions that a physician can make with the agreement and with the company of the family. And therefore, nurses do not have the right to say we're not giving pressors. Nurses do not have the right to say that we are giving pressors. Those are decisions that the nurses are supposed to be carrying out the wishes of the family and the orders of the doctor. It's not within their purview of practice. This is a legal term. They are not allowed to make those decisions. We often abdicate those decisions to them, and they're often highly qualified. An ICU nurse who's been there for 20 years knows an awful lot more than the intern on service that month. But at the same time, they shouldn't be making these decisions. They're entitled to speak with the doctors, speak with the family. They're entitled to give their opinion. But ultimately, it's not their decision. And I want to give equal time to Rabbi Brody, so I'll thank you very much for listening.
Thank you very much, Rabbi Glatt, for a very enlightening discussion. I think we probably could have spent some more time on this and maybe have an open session tomorrow. There will be a session which will be, there will be two sessions tomorrow I want to point out. One will be discussing some medical issues, medical cases that we are going to ask the panel, and some of these topics are going to be addressed. And then, of course, tomorrow at Sudash Lishit, at Shalosh Shudas, there is an open Q&A. So that's always an opportunity to be able to catch up a little bit. While we're setting up over here, Rabbi Brody will be now discussing organ donation. I hope you had an opportunity to, we have the project renewal. And if anybody, people familiar with the organization, it's a wonderful organization based in the United States. There's a Canadian branch. There's a branch in Toronto specifically, and really they make it a point about live organ donation. So that's a different topic than we're going to be discussing right now. Right now we're going to be discussing the broader topic of organ donation from the various different ones. But I encourage you, if you have an opportunity over Shabbos, to be able to reach out, speak, find out a little bit about organ donation. Tomorrow, Rabbi Steinberg will be co-hosting one with Rabbi Jaffet not tomorrow, this afternoon at 2:30 on live organ donation. So this is really a wonderful opportunity. But for now, I'm going to turn over to Rabbi Brody, who will be discussing the much broader topics of organ donation in general. Rabbi Brody.
Okay. So Rabbi Steinberg is going to be speaking about respiratory brain death and organ donation. Shkoyach. Thank you. On after brain death, and there'll be live discussion. I'm actually talking about the future and the non-known present of organ donation, and I want to explain what I mean by that. So the title is When Death Becomes Reversible: Medical Innovations, Time of Death, and Organ Donation in the 21st Century. And I'm stressing this is a 21st century conversation, not the 20th century conversation. What I mean is, we're all familiar with the great debate, machloket, etc. I'm not going to say who's who, because there's a debate about who says what, right? About the issues of brain death and organ donation. I'm talking about what's going on now, the innovations which are probably not even many people aren't aware of, and what the future might bring, and what halacha might have to say about these questions. Okay, so no conflicts of interest here of grants, and we're going to try to understand the new ethical dilemmas and appreciate potential Jewish approaches. So, my friends, even if you're not American, but you'll be familiar with Benjamin Franklin, who at the time of the founding of the United States says, our new Constitution is now established and has an appearance that promises permanency, but in this world nothing can be said to be certain except death and taxes. Now, given what's going on in the United States and other countries around the world, I can tell you I'm not so sure that the Constitution is going to last. And given what I'm about to show you right now, I'm not sure that death is going to last, but I can assure you that taxes will always be with us. So I don't know if this is a up wave starting or a down wave starting this year, but let's just put that in perspective. And here is what seems to be the future. So you might have seen this in last summer. This is finding I think Nature magazine wrote it up, but it was widely reported, where pig organs were partially revived in dead animals. And what they did was they killed pigs, waited an hour after cardiac arrest, and then threw in a tremendous amount of blood substitutes, which was comprised of animals' blood and various compounds, and got organs to renew their vitality. An hour after the pigs are dead, by all definitions, by all appearances, right? They then use this blood substitute and get organ vitality going again. Remarkable. And by the way, this is a couple of years after the same group had done something similar after brain death. In fact, that case was 4 hours. So what the future seems to bring, or bear, could be, we don't know, right? But what seems to promise is that we're going to have a situation in which people are dead. By any definition that we know of what death might be, which is normally, how do we define death? No, before you get to that, what is the one thing we always say which makes death so difficult? It's irreversible. And suddenly, what does this mean when the criterion that we usually think of what is death is suddenly now reversible? Is that meaningful? Do we care about it? Does that change the status of this organism being alive or dead when you can now reverse what we thought was the irreversible cessation of a various type of function? And now all of this is already going on, but we should understand that while this might be a bare future, and scientists are talking about those issues greatly, right? But the issue of organ donation today in the Lamasseh, in Canada, in the United States, and everywhere in the West but Israel, I'll explain to you why not but Israel, is that there's many new times when organ donation is happening. So traditionally in the world that we live in, we think about organ donation as what's known as DBD, right? Donation after brain death. Okay? But in many places around the world, between 25 to 45% of the cases of organ donation are actually happening after DCD. Donation after, we'll call it for now cardiac death, although we'll see why we should be calling it circulatory death. We'll come back to this. Okay? And what the donation after cardiac death protocol allows for is there are times when there's cardiac death that occurs, and we can retrieve some organs then. There's a protocol, we'll discuss momentarily which organs, which allows. Now, when I first learned about this, I'm like, oh, this is amazing, because this will end all of the halachic issues, right? Because we have all this debate about time of death, brain death, not. Everyone agrees cardiac death is halachic death. That would be great. But the problem is that in the vast majority of countries and cases right now, DCD is happening in what we call a controlled circumstance, CDCD. And in CDCD, the way we're doing this is withdrawing care, which Rabbi Glatt was referring to beforehand. Let's say removing a respirator, waiting for cardiac death, and then immediately you're retrieving organs. Now that's, on the one hand, is after death, but according to halacha, which we'll discuss other times, is problematic because you are hastening the death or causing the death. But this is going on already. And so it depends where you are and which hospitals in different places. In Southern California, it's about 25% of organ donations. In Northern California, it's about 45% of organ donations. In England, it's almost 50% of organ donations right now are coming from DCD. Now, historically, meaning as of 12 years ago, right? We're talking really new stuff. This was not possible to retrieve a heart. More or less, wasn't possible. Of course, was a shortage of hearts. And so part of the techniques and protocols which were being developed now says, well, maybe we can manipulate the situation in a way in which we can pull the plug, but in a way in which we can create cardiac death, listen to this out, then immediately stop brain circulation to the brain by closing off blood circulation to the brain, and then getting the heart to start again. You got it? You got cardiac death. You then cut off the line so to make sure that there's not going to be any restored circulation to the brain, which then it causes brain death. And then you get the heart beating again. Pretty crazy, right? And then you start to ask yourself, well, what just happened here? You withdrew care to get the heart to stop. Then you cut off the circular lines so that way you don't get the brain going again. And then what do? Get the heart going again. Forget about the question whether you've killed someone or not. Is this person dead? Because what did you declare the person to be dead with originally? Their heart stopped. Then you say, no, we're going to brain death. And then we're getting the heart going again. Is this a good thing or a bad thing? Well, it allows us to retrieve hearts. So you could say that's good. And it allows us to retrieve hearts in cases where a decision has been made beforehand to declare that continued medical intervention is no longer appropriate or necessary, and therefore we'll withdraw it. So you could say, we're now just manipulating the situation in a way where they're going to die anyway. Let us allow some life to come from this. But you understand you're playing a lot of games with what's death. How are we defining this? And of course, as with all medical innovation, I say all, but with many cases of medical innovation, what's going on in the hospitals is faster than the law can catch up to it, which is an interesting phenomenon in its own right. And so there's a major, now I'm highlighting this machine for a minute, right, as part of the method, because I want to understand this is questions of how we use technology. Now, if you look at the ECMO, right, it's amazing. ECMO is amazing. It's amazing. Just acknowledge that. It's amazing we live in an era where we have machines like this. But raises tremendous amount of questions about how we use technology ethically or not. And so there is a major statement from the American College of Physicians in April 2021 where they basically said what you are doing, i.e. transplant doctors, is wrong. Because you're playing around with the definition of death in ways which are so manipulative that it starts to raise questions about what used to be the classic standard of organ donation, namely the dead donor rule. We do not take organs from someone who's not dead. Period. That is the standard rule, or has been the standard rule. And what the American College of Physicians are saying is once you start this, the procedures and operative definitions used to determine death seem orchestrated to serve that end. Loss of circulation wasn't irreversible. How do you know it wasn't irreversible? Because you got it going again. So how can you say, right, you are orchestrating a death? The intent, however, is to reinitiate circulation. And the patient is, in fact, successfully resuscitated. But they'll say back, yes, but in the meantime, they're brain dead. Answer, you manipulated that brain death. How did you manipulate that brain death? Because you prevented brain reperfusion when circulation is restored. The purpose seems to justify reversing what was supposed to be irreversible. Are they right? So in response, a number of ethicists who are in defense of this method have said the following. Said, listen, what we care about isn't the fact that we got the heart beating again. What we really care about is not the heart, but the function of the heart. And they say as follows: the irreversibility as defined is the function of the organ within that person. During NRP-C DCD, right, controlled donation after circulatory death, the organ's inability to function within the organism was confirmed with the determination of death. And here now they get into the question of intent. There is an important difference between resuscitation with the intent to alter the ultimate outcome and the use of extracorporeal circulation to perfuse organs. Right? Intent matters in these circumstances, and therefore we can declare death because there is not the irreversible cessation, but permanent. Now this is a machloket. This is a disagreement even within cities. So for example, if you go to New York City and you go to a Columbia hospital, where Ken Prager's there and Lydia Dugdale's there, they won't do this. You go down to NYU, they're doing it. By the way, just understand, as a side, the motivations here about saving lives and what's ethical. But you know how much money you get paid for every heart transplant? So it's a massive amount of financial and economic repercussions to this question, which they're doing at NYU, but not doing at Columbia. Now, part of this discussion, of course, is this distinction between irreversible and permanent meaningful or not? And you understand that what's going on right now is the ways that we can manipulate and change and alter what happens with which organs stop and how they function, and whether we can get them going again in a manner which they'll be vital but not restore full functioning has become a critical definition. And the question becomes, right, does halacha have anything to say about this? So this is not from a book by Rabbi Shlomo Brody. This is actually a book from Rabbi Shlomo Goren. But I was doing this as I got into a plane and I was typing something else. So please, I don't want to take away from Goren's credit here. I was writing a number of different shiurim and articles at the time. So Rabbi Shlomo Goren, I noticed this morning, made a very interesting distinction already in the 80s. And he says there's a difference between a heart and a heart. What is the difference between a heart and a heart? There are trei dinim in a heart, right, if you want to use lumdisha terms. There's a heart which has a functional purpose, and there's a heart which is biological organ. Death occurs when the heart no longer functions for circulation. The fact that you can get the cardiac element, right, the organ, going again, revitalize that vitality is irrelevant. The heart only matters, is significant when it's causing a full amount of functionality. Does this point to an argument which says that this would be a definition of death which we can accept? Maybe, of course, if you don't have to ask the questions of manipulating the process. And so we have to start asking again, as we've been doing for many years already, what is death? Okay, because right now you understand we are playing around with the body in a way in which this notion of irreversibility, which always seemed to be what death is now very questioned. And the technology is getting more and more powerful to question this. So, death, is it a moment or a process? So here you have two different figures who have very different positions, as is well known, on the issue of brainstem death, right, and organ donation. Rabbi Bleich Shlita on one side, Rabbi Steinberg Shlita on the other side, and both of us will tell us the same thing, though. Death is a process. Meaning the death definition, and therefore the definition of death, let's see from Rabbi Bleich, cannot be derived from medical facts or scientific investigation alone. Science will tell us how the organism, right, will stop working, will describe to us in general about the physiological state, but the determination when you say a person has died in that process of dying is going to be ethical, religious, cultural, whatever it might be, but the scientists can only tell us so much in terms of describing what's happening to the organism. So let me give you an example. If you have flowers on your table from last Shabbos, you forgot to get rid of them. You come home on Sunday, and they're sort of, are they dead, are they not dead, there's water, but they're dead. The answer is, who cares? Right? In other words, we don't really care. You decide, you throw out the flowers today, tomorrow, whatever it might be. But you understand that you could argue, right? You could see people in the family arguing. Are they dead? Are they not dead? Who didn't put the water in, right? May or may not happen in my house, right? Etc. But we don't really care. With humans, of course, we care. We care a lot. And not only do we care a lot because of the Tzelem Elokim that we care about, making sure that we keep people alive and don't kill people, but also because of the implications of organ donation. So we know that halacha has a moment of death. How do we know that halacha has a moment of death? What halachic concept tells us that halacha has a moment of death? Tuma and Tara. We know that someone's dead. When someone is dead, right, then they become metameh. But there's always been a little bit of this question, right? How do we know exactly if a person is dead? So this was not always a perfect process. If you look in the Mishnah and Smachot, they have a number of stories. It once happened that a man who was buried was examined and found to be living, and he lived for another 25 years. And they talk about even waiting a few days, and the Shulchan Aruch brings down the question about whether we can always know when a person is dead or alive. This has not always been a perfect process. If you really want great bedtime reading, I recommend a book called Buried Alive. It is as it sounds, okay? And it's a book about the great fear over many centuries of people being buried alive. But don't worry about this, except for just to note that in both New York and Indiana this year, people woke up in the morgues. Which only means to tell you that this hasn't always been a perfect process. But I don't want you to worry about this, really. Meaning, we understand that this hasn't always been a perfect process, but we've been able to know when a person is dead. I know when I see it. Now, has halacha been concerned about this? Not so much, because we understand when a person is dead. My famous beloved line of the Chidah, if in one of many tens of thousands of cases it happens that he's alive, does it not devolve upon us to slay his transgression? For so it has been decreed upon him. Meaning, v'kach nigzar alav, meaning if we accidentally buried someone alive, you know why we did that? He was chayiv misa anyway. I don't think the Chidah would have cut it as the pulpit rabbi. Can you imagine the Proba Shabbat? Rabbi Azulai, what would you say to a family if we accidentally bury their loved one alive? Have no fear, he's chayiv misa anyway. No way he's getting the job. Okay, but you understand, but in general, right, there is this understanding that we've understood what death is and can see it. Now, the problem is, what happens with technology today? Technology has transformed this question. So Professor Steinberg will get into all the discussions about the test that gets into the Gemara and Yuma, has this famous question. You find someone, you're not sure they're dead or alive. They're not responsive. What do? What does halacha say? The feather test. The feather test, as brought down the halacha Shulchan Aruch. There's a big machloket, though. And by the way, it's very interesting. If you look in the Shulchan Aruch Rav, his formulation here is very interesting. He says there, Ikar hekar chiyutu b'chotem. He indicates to us that it's not just a test, but the criteria for what it means to be deaf is the element of whether or not you can see breathing in the nostrils. And this became, of course, the big fight. Do we accept respiratory brain death as halachic definition of death or not? Do we learn from this Gemara, which gives us the feather test, that we also have a criterion for death? And that criterion for death is the cessation of respiration, the irreversible cessation of respiration. Rabbi Moshe Feinstein, at least according to his son-in-law of Moshe David Tendler, accepted this definition, and others did not. With Zilberstein, for example, being representative of saying to the fact that it's only a test for death if there's no signs of life. But if the heart is still beating, there's a sign of life. To which Rav Moshe said in response, no, right? Even if the fact that there's a sign of life because the person's heartbeat is still going, the criterion for death is the irreversible cessation of respiration. By the way, fun fact, where does Rav Moshe write this fact? Everyone always says it's from the Igros Moshe, right? Because that's where his Chuvas are published. Not true. It was republished in the Igros Moshe. In 1976, when Rav Moshe wrote this Chuva, it was sent out to every member of the Association of Orthodox Jewish Scientists, with an English translation and 5 pages and an explanation from Rav Moshe David Tendler, his son-in-law. Which means that if this wasn't his position, and he had changed his mind or didn't mean it, you might have expected that to have been clarified in the forthcoming newsletter, which it wasn't. But nonetheless, there's a big dispute about it. I don't want to get into this issue. And therefore, but here's the point. It was irreversible. It was irreversible cessation of respiration. The chief rabbinate and every single religious Zionist rabbi in Israel have accepted the irreversible cessation of respiration as the halachic criterion for death. It's the only thing that religious Zionist rabbis actually agree upon. Which is a pella, except for a positive, right? What do we do in Shemitah? What do we do in Kashrus? What do we do on Geirus? Women's issues, army issues. Religious Zionist rabbis can't agree upon anything except for this issue, which is really remarkable. In the Haredi world, in practice, no one holds of it. They do not accept the respiratory brain death. And in the Chutz La'aretz, it's a big fight. And no one wants to talk about it. Okay, now, I don't want to get into this issue because Professor Steinberg is going to talk about it later. What I want to discuss now is the following. What happens when all this discussion becomes moot because it's not irreversible? When everything becomes reversible. Do we have any precedents to talk about this? So I saw here this famous story of Elisha and his resuscitation. What exactly was going on in this story? Remember the story in Malachim? Right? He picks up the child and brings it to the mother. The boy seems to be dead for a while. He leans over him and what? Resuscitates him. So some people love to say, oh, we had it first. As we had in Tanakh, he did CPR, this or that. Is this CPR? No, I don't think so. I mean, I know some people love saying that. I think this is what we call a miracle. Right? In other words, like, I don't know. Maybe this story is, maybe it's not. But I don't know. I don't like reading it that way. So I don't have much to learn from this. But there's a very interesting question to think about. Person, what happened to this boy? Let's say this boy wasn't a boy. He's married. Okay? So he's married. And his heart is stopped for 30 minutes, 40 minutes, whatever it might be. 20 minutes, doesn't matter. He gets resuscitated, hops off the bed. Does he have to get remarried? After all, how does a person marriage stop? Two ways, divorce or death. So this is the great shaila known as, is there wife after death? Right? Is the wife after death? Because if you think about it, wait a minute, he was dead or wasn't dead. So this actually was asked as a shaila in the 60s. It's really fascinating, 60s or 70s. And it was actually by a Kiruv rabbi who wanted to ask certain things, like maybe this proves that there is life after death. And from that discussion got into the debate about whether there is wife after death. Okay? And it turns out it may even be a machloket, which is sort of awkward, but in general, we understand today that certainly we don't consider that 20 minutes or 10 minutes or 5 minutes when the heart wasn't beating that the person was dead. Why not? Because it wasn't irreversible. We might have thought at the moment it was, but then it turned out to be not the case. So the fact that we found out afterwards it wasn't irreversible means that they're not dead. So the question then becomes is, what happens if the technology allows everything to be reversible? Which doesn't mean we're going to do it, but we could do it. Because we could perfuse the body in this way in order to get a heart beating again. But the question, of course, would be for what? For what purpose? But again, it's not irreversible. It might be permanent loss of circulatory function. It might be permanent loss of respiration. But you are able to get the organs vital and going again. Because nothing anymore is irreversible. It's a scary thought in some ways. Right? On the one hand, we hate death because death is irreversible. So this should make us happy. But this isn't what we had in mind when we wanted death to be reversible. When we want death to be reversible, what do we want it to be? We go back to normal. We hop off the bed like the boy with Elisha. this ain't what we wanted. And so now we have this tremendously powerful technology, right, to perfuse organs in a way to restore vitality, but not in the way that we wanted it to be. So what happens then? Do we even have a moment of death anymore in such a world? And of course, you have to ask as well, what has happened with the world of organ donation? Because again, even if you hold, and this is very interesting to keep in mind, by the way, I mentioned there's something called controlled donation after cardiac death. There's also something called UDCD, uncontrolled donation after cardiac, or let's call it circulatory death. This is being done primarily in Spain and in France, but in other places as well, various experimentation with it, in which they have situations where in an uncontrolled manner, we're able, right, we have a case of cardiac death, and organ donation is possible in those circumstances. In fact, in the living will, which we're going to be showing you in the next session later today, a Matthias living will tells people you have an option to donate after death has been declared by the criteria of Jewish law. Why did I formulate it that way? Not just because I wanted to avoid the brain death debate, but because I think the next 10, 20 years, whatever it might be, donation after cardiac death in an uncontrolled manner is going to be greatly possible, which is going to open the door for a tremendous amount of halachic donation, but it won't open any door if everything's reversible. So should it matter? So let me ask you the following question. Can we sacrifice our chaye shah, our last moments of what we would call life or suffix life, in order to save others? In general, can we sacrifice our life to save others? It's a very fascinating question. Let me give you the following scenario. Suppose you have a gosses. Everyone agrees the gosses is alive, but someone who's clearly in the dying process, maybe the last day or 2 days, let's say it's even the death rattle. Right? We have a real feeling this is going to happen. And you're in Soroka Hospital, and let's call the patient Roi. And you're in Soroka Hospital in Beersheba, you got 8 people around, you got the mom, you got the dad, the siblings, you got 2 doctors, 2 nurses, and they're all sitting there waiting to stand be the present when the person dies, or Marie dies, and suddenly a grenade is thrown into the room. And there's nowhere to run to. But someone says, Roi's a gosses. He's going to die anyway. Let's throw his body on the grenade to save the rest of us. Would you do it? Would you do it?
No.
What if Roi in his lifetime had said, if I'm a gosses and a grenade is thrown in the room and I can save 8 people, throw my body onto the grenade. Would you do it?
Halacha says no.
Would it be? I think halacha says it's mutter.
Roi did.
Of course. So who's the Roi I'm talking about? Roi Klein. Threw his body on the grenade in the Second Lebanon War. Save his comrades. I think it's mutter. And so if that's the case, right? If that's the case, you start to ask yourself questions, right? Can you save, right? Sacrifice the terminally ill to save others? Because remember, the case of this deaf person might not be irreversibly dead, but there's a permanent loss of total functioning. So you're in this limbo zone, which is even much worse. Would we allow it in that case? But you understand, friends, if I start making the argument that we can save the lives, we can sacrifice the lives of the terminally ill to save others, where am I going with this? You know where I'm going with this?
Medical assisted.
No, I'm going to Canada.
Oh, that's what I meant.
Because every year in Canada now, there are over 50 cases of euthanasia organ donation. Person's not terminally ill, suffering greatly. And he says, I want euthanasia and I want my organs to be taken. I literally just got this question from someone in Yerushalayim who's got Alzheimer's, who wrote me. I know you're involved a little bit in the world of organ donation, which actually my organization is much more focused on broader end-of-life issues, but he asked me, I want to do euthanasia in Israel and donate my organs. Now, Israel doesn't do DCD, donation after cardiac death, and we don't do euthanasia. So I said to him, I sent it back to a social worker I work with, mental health professional. But you understand that if you start making these arguments that we don't know when death is, but we can sacrifice, well, where do you draw the line? It's a very dangerous argument, which is why I'm very, very hesitant to make such a claim. Which then brings us to our question, though. Nonetheless, could we say that even if we're in this middle zone, we have a suffix whether the person's alive, because they're not irreversibly dead, could we sacrifice them for the sake of others? So this argument actually was made by Moshe Steinberg. Moshe Steinberg is the head of the Eidah Charedis. There's no chashash that he's been somehow corrupted by modern values. They're the Eidah Charedis. And Moshe Steinberg asked the following question. When it comes to this issue of defining the moment of death, why does it matter? After all, if a person is brainstem dead, for example, they're clearly in the category of a gosses. We can say we can sacrifice the life of a gosses in order to save others. It's very fascinating. I made that argument. He doesn't take this to l'maaseh, but he says, mutar lo limso et chayav latzalat chavero. If that's the case, and we continue to create all these in-between gray zones, is a person dead or alive, and it's well beyond the questions of brainstem death now, could we say, well, in those cases, can we limit it? Now, Shlomo Zalman Auerbach Zatzal didn't like this idea one bit. Shlomo Zalman Auerbach said, no, we do not sacrifice that way and allow people to sacrifice. And so you have to ask doctors to cause the death of a suffix. Either we've got someone's dead or he's not dead. We can't be in this limbo zone. In fact, to the point, and this is the least followed psak of Shlomo Zalman Auerbach, the least followed psak of Shlomo Zalman Auerbach was that you cannot not only donate organs in Israel, but you can't even receive organs in Israel. No one holds to this psak in every direction. But why? Because he said, if we don't think this person is dead, we can't support a system that promotes that definition of death, which doesn't follow halacha. Shlomo Zalman wanted a clear definition of death one way or the other. And then the question now becomes which is very intuitive to me. I would like to have a moment of death. But what happens when science is making everything reversible? In some sense, but not in other senses. This is going to be the great dilemma of the next bunch of years. Because the organ donation debate that we know and love, right, from the 60s and onwards, which is still going on, which is still very relevant, the D family, right, it's all very relevant today, but is slowly but surely going to be transformed as the technology changes and we can revitalize organs and revitalize the body in a certain way well after any definition of classical definition of death. And the technology is basically already here. And it's only going to be developed more. And it's going to be developed more because we have a real incentive, a good incentive in some ways, in order to save lives by increasing the number of organ transplants. But look what the American College of Physicians was saying. You're playing around with the definition of death. And friends, I'll end with this thought. I'll take a few questions. But as always, the technology is advancing faster than the ethics and the law. And so if we're not thinking about these questions, we're going to wake up the next day, and all of a sudden, death has been transformed. Maybe it's a good thing, maybe it's a bad thing, but we should be thinking about it. And im lo achshav, imatai. Questions? Oh, microphone.
So, questions of donor aside, are we allowed to approve the use of an organ from a made donor? Or it could get even worse. In China, they use organs from executed prisoners. If the organ is procured that way, can we accept it?
Yeah, so this is a major issue. So the Chinese case came up because of someone I'm friendly with, who's a transplant doctor in Sheba Hospital, Jay Lavi, had a patient come to visit him. And the patient said to him, Jay, I'm getting a heart in 3 weeks. So Jay says to him, that's not exactly how it works. He says, no, I'm going to China. My insurance is paying for it. And I'm getting a heart. And that's what he did. So Jay started looking into it. And he realized that the Chinese were killing political dissidents, Falun Gong and others, and then giving their hearts. And Israelis were going there because they want to live. And so Jay made a big tumult about it. He's written about it. And Rabbi Yosef, to his great credit, came out and said, this is absolutely usser. Even though we all want you to live, you can't go to China in order to get an organ when it's been done by killing someone. What's fascinating is that Rabbi Yosef initially seems, at least he told Dr. Abraham, that he agreed with Rav Shlomo Zalman that in Israel, where we can have some influence over the system, you can't receive an organ after brain death there as well. And then there's this famous case where a young teenager who needed an organ went to Rabbi Yosef and said, I don't want to take an organ if this is usser. And Rabbi Yosef said, no, you can take it, it's mutter. The question is why? How do you reconcile those two psakim? Because he thinks it's usser to do it in the case of China, but he doesn't think it's usser when you are suffix killing him, according if you don't accept brainstem death in a regular DBD case. I think the answer intuitively somehow relates to this. When we have a suffix dead person, when the person is permanent, right, damage, right, permanent loss of respiration, which may no longer be irreversible, but is, at least according to today's medicine, still irreversible, he'd allow people, if they're going to do it anyway, for you to take it. But you understand that once you start saying that we're going to allow other people's definitions of death in order to, and then accept that to take organs, that gets very tricky. And so when you're in Canada and you need an organ now, and you know that there are going to be numerous cases a year, which is only going to increase, where this was done through euthanasia, it raises a lot of questions. And so if you don't have this notion of allowing self-sacrifice in order to save others, I think it raises a lot of ethical issues. So I'm not answering your question because I'm not sure yet what to do with that.
It's a whole spectrum. Is that it is self-sacrifice. If you go to India and you bought a kidney from someone who's willing to sell it, it's just still on the spectrum of self-sacrifice. They're not doing it out of any altruistic reasons. They're doing it because it's the only way they live.
Right. You understand? Yeah. The point you're making is excellent, and it raises the question when we're manipulating bodies for the sake of transplantation, which is amazing, right? Because we can give the gift of life. It's incredible. But as the technology keeps on developing, we're going to be getting ourselves into very, very difficult questions. Which is why I would like to be in a position where we can say we have a definitive moment of death. That's where I want to be, because we can draw a line and preserve the dead donor rule. I believe in the dead donor rule. I just don't know if science is going to let me have that anymore. Yeah, pass the mic. Is there a question, even when a person is declared dead, according to everybody's definition, but you can revitalize organs, is there any issue of defiling the dead? So, in general, defiling the dead is always a question. Right? We don't normally would not manipulate a corpse in this way. But if they're dead and they can save a life, pikuach nefesh is docha the isurim of nivol hamet or hanat hamet or halan hametim even. Right? So that's a critical point. It's true, we normally would not allow us to, this is the whole issue of autopsies and medical study, right? In general, we don't allow the benefit of a corpse in this manner. This is a little bit more complicated than I'm making out to be, but that's a general rule, of course. But here you have a sakanas lefanenu, right? You have a person in front of us. There's always, when it comes to organs, a need. Someone has a need for that organ. So that's why that would be mutter in that case. If you think the person is dead. If you think the person is dead. If you don't think the person is dead, you're in tricky grounds. You're in a tricky spot. Does that require pre-mortem consent by the person who has died? So this is interesting. Who defines death? Because in pluralistic societies, when people can have multiple connotations of one is death, you get into questions. Well, if this person thinks that they're dead, but you don't think they're dead, but they think they're dead, does that matter or not? Those who don't accept respiratory brain death according to halacha, which are many great poskim like this, many great poskim who I greatly respect, don't accept it, but they say that you can still receive organs because they say the person has decided for themselves that this is the definition of death. Society accepts it. If they're going to declare themselves dead, you can still take their organ. That is the argument that is made in order why you can take but not give. Next question. There's another. Yes.
I thought this is a problem when they're doing massive organ sharing in Europe and in Israel. And Israel was very keen to receive organs, but not keen on donating organs. Right. And therefore, then they decided maybe not to share with Israel to get organs. Right. So is that now...
Israel was kicked out of the European Sharing Network because Israel was taking too many organs but not giving enough. The organ donation rate in Israel has gone up. So it's about 56% agree to donate organs after brain death, which is a real improvement, but it's still much lower than the rest of the Western world. Okay, now, you understand that Israel doesn't do donation after cardiac death because of all these issues and withdrawing care, which means that the number of organs available in Israel is inherently going to be limited for two reasons. A, you have large segments of the population that don't accept brain death, and B, you don't have donation after cardiac death. So one of the things I've been working on a little bit on the side is to try to get Israel to start following the Spanish and French model, to try to explore cases of uncontrolled donation after cardiac death. But it's complicated. There are a lot of complicated issues with it as well, both ethical and other reasons as well. But that is going to be the issue in Israel. And Israel is going to have a shortage of organs, except that Israel has the highest per capita rate of live donation, of kidney donation, altruistic donation. And so there's a lot of organ transplantation going on in Israel because of people donating their kidneys. And since kidneys are the number one organ that's needed, it's about 85% of the organs that are needed, that helps reduce the list overall. And so if you want to solve the problem, if you want to try to increase the number of organs being donated in Israel, your best method is going to be to increase the number of live kidney donations going on because of various reasons that donation after death is much harder to achieve in Israel. Yeah?
Can you explain what you mean when you say Israel doesn't allow donations after cardiac death? Because certainly they allow kidneys and cornea and everything after a person has died.
Sorry, I should be clear about that. Israel doesn't have DCD protocol, which means that they'll allow corneas to be donated or heart valves to be donated. But in terms of the life-saving organs that we're talking about here, kidneys and livers, this or that, which is done by the CDCD, the controlled donation after cardiac death, Israel doesn't have because the Israeli law forbids withdrawing treatment in a manner that will lead to immediate death. And the only way you can do this, because organ donation is such a sensitive, time-sensitive process, is by doing it in a very controlled manner. Because if you don't do it in a controlled manner, the organs won't be vital anymore and be no good for retrieval. And so since Israeli law is actually, this is the one law in Israel which actually follows halacha. Meaning, it's very fascinating. People think, like the marriage law in Israel and divorce and not selling pork and whatever it is, none of this stops any isurim going on. Right? Nothing. You don't let someone get married, they break up? No, they go to Cyprus or they just live together. And you don't let people, sell chametz in public. Did people stop eating chametz? No, there's something called freezers, right? In other words, all these things got to buy. This is the only law in Israel which is actually governed by halacha after a 59-member committee led by Professor Steinberg came up with a law on the terminally ill. And one of the things that came up with is you can't pull the plug. If you can't pull the plug, you can't have controlled donation after cardiac death in general. We'll see. Again, the technology is amazing. So it's going to raise all sorts of questions, but it might destroy the dead donor rule. Are we happy about that or not? I feel like I'm ending all of my lectures on a very depressing note. So let me just highlight the fact that this technology is amazing. It's amazing. We just need to think about this in a profound manner and try to work this out. Try to use technology in ways which are ethically and halachically sound, which is doable in my mind.
This is an issue which can be thought through. We can address this issue if we're aware of it and willing to confront it. And that I actually think is a positive message, because it's very exciting. Right? We're on the frontier, and we should be on the frontier. And if we combine our powers as rabbis and doctors and caring citizens and whatnot, we can address the pressing ethical issues of our time. Thank you very much.
We're going to have our second session this morning, and we'll be discussing end-of-life issues. Again, we'll have Rabbi Steinberg and Rabbi Brody addressing us. For the first topic, and it was already mentioned, this is the most important topic of the conference. I wouldn't say that, because I think they're all going to be important, and everyone will find their niche and their space. The reason that this may be for some very important is because there is an axiom in medical halacha which is the fundamental basis why the whole DNI issue comes up. So DNI, just the terminology, is do not intubate. So for decades, the axiom has been there is a concept of DNI, do not intubate, because the assumption has always been once you intubate, and we will discuss today that the issues are going to be withholding versus, as we've already been introduced, withholding versus withdrawing. But once you intubate, the assumption has always been that one may not wean or extubate, because that, of course, would be an active process, and that would be prohibited. I would like to ask Rabbi Steinberg, of course, to come and address this issue and shed some new light and some Torah and some halacha on this.
So, as Dr. Friedman said, one of the more complicated situations in halacha regarding end of life is what do you do with someone who is already on a respirator? As a preliminary note, it is permissible, according to most poskim, in certain circumstances, not to start a respirator, not to intubate someone and put him on a respirator. But once he is already on a respirator, is he stuck for a long time, or are there halachic ways to change the situation? Just to put things into perspective, this you already saw several times, right? So you are witnessing that everything is okay for the CME and you can get it freely and happily. Okay, so respiratory support or resuscitation, in principle, probably is already a Tanakhic occurrence. And there were two such instances, I assume everyone knows. One was Eliyahu and Ben Atzorfatit or Atzorfatit, depending on where it is written. And the story was that the son of the hostess of Eliyahu had a choli chazak me'od, asher lo notra bo neshama. He was so sick that he couldn't breathe. Was he dead or not, we'll see in a minute. And what did Eliyahu do? He came over the child for 3 times, davened, and apparently put in breathing into his nostrils, which is not stated specifically, and the child woke up. So the Ralbag says that indeed he made himself as if he is putting mouth to mouth and doing mouth to mouth resuscitation, but the Tosfot in Bava Metzia, and we'll see in a minute, asks, we know Eliyahu was Pinchas, and Pinchas was a Kohen. And if the child was dead, how was he allowed to be metame to the dead? So says the Tosfos, שהיה ברור לו שיחייהו, לכך היה מותר משום פיקוח נפש. He was so sure that he'll revive him that it was a situation of pikuach nefesh, and hence he was allowed, even though he was a Kohen, to be in touch with the dead. Because it seems like he actually touched and it was over him, which is halachically a ohel. And a Kohen is metame be'ohel and metame b'maga umasa. So he did all 3 forbidden acts of Tumas Kohanim, but according to the Tosfos, that was a pikuach nefesh situation. The Rambam in Moira Nevuchim holds that he was very sick, but not necessarily was he dead. So this wasn't a situation of resuscitation in the sense that the Ralbag understood, in the sense that the Tosfos understood, that indeed he was dead and Eliyahu revived him. This was just a situation of a serious sickness, difficulty breathing, and therefore Eliyahu could resuscitate him, but not from death to life, but from a serious sickness to a better situation. This obviously takes away the kasha of the Tosfos because he wasn't dead. So a Kohen is allowed to treat a sick person. And the same says the Radak, that some say that he wasn't really dead, he was just very sick, and others say that he was really dead and it was a resuscitative measure. There's an interesting tshuva, a whole tshuva devoted it by the Radbaz, who says, שאלת ממני למאן דאמר פנחס אליהו, האח נטמע להחיות בין הצרפית. The same kasha that the Tosfos asks, and he brings a whole host of tshuvas, what happened there, was it a tumor, wasn't it a tumor, even going to the degree that this child wasn't a Jewish child. He was a goy, and a goy is only metame be'oil, but not b'maga u'masa. On the other side, he's metame b'maga u'masa, but not be'oil, and according to this explanation, he wasn't really above the child, but next to him, doing his procedures next to him, so he wasn't in an oil, and although it says alav in the Nesim that were walking in the desert, it says ve'alav mateh zeh, ve'alav mateh zeh, meaning not on top of him, but next to him. But there are many tshuvas, we won't go into it, this is a very specific, but I thought it's of interest when we're talking about resuscitation. And obviously the second case was Elisha and the son of the Shunamite, and here everyone agrees that he was dead. Elisha wasn't a Kohen, so all this shilas about Eliyahu did not apply, and he did the same procedure that he puts his mouse on top of his mouse and revived him. And there is a third hint that this was something known. This is Balaturim on the beginning of Shmos. The Torah says, Shema Achat Shifra v'Shema Sheni Pu'ah. Why was Miriam or Yocheved called Shifra? Shifra is from the term Shfoferet, because he says when a baby is born and sometimes he's not starting to breathe right after birth, so she would take a tube, put it in his mouth, and blow air into it, which is intubation. And instead of machine, it's the person who is doing a real respiratory resuscitation, and that's why she was called Shifra. So the concept that you can revive someone who is not breathing by breathing into his mouth and nostrils, that is a concept that is already from biblical times. Now, in order to understand the halacha in current days, obviously there is mouth-to-mouth resuscitation, but that is not the issue. The issue is a resuscitation with a ventilator, with a respirator, with a machine, that needs some qualifications. So first of all, there are some distinctive concepts in halacha that actually were developed in the format that we now teach it, was by Reb Shlomo Zalman Auerbach. He really made order with all the various types of treatments in end of life, how to define them, and what is permissible to withhold or to withdraw, and what is not. So the first distinction is between Chayei Sha'ah and Chayei Olam, and obviously everyone knows that Chayei Sha'ah doesn't mean 1 hour, and Chayei Olam doesn't mean immortality. Both are wrong. These are just terms. Chayei Sha'ah means temporary life, and Chayei Olam is what is beyond Chayei Sha'ah. but even Chaye Olam is Chaye Sha'ah. At some point, the person will die. How do you define Chaye Sha'ah and how do you define Chaye Olam is important, but at the moment I don't want to go into it. We discussed it in previous conferences, but I'll say it very briefly that Chaye Sha'ah, according to most poskim, is defined as expected life less than 12 months, similar to the definition of treifa. Treifa is mentioned in Chazal that it is 12 months. Chaye Shor is not mentioned at all. How long is Chaye Shor? The Gemara distinguishes between Chaye Shor and Chaye Olam, but doesn't define how long is Chaye Shor. So the later poskim equated it to treifa, and Chaye Shor is someone who can live 12 months. In the Israeli law, when we enacted the law on the dying patient, we reduced it to 6 months. We called a dying patient or a Chaye Sha'ah 6 months because there are no statistics for 12 months. So even if we'll define that a person who will die within 12 months has a different set of rules than someone who will live longer because he's Chaye Sha'ah, we can't medically say that someone can live 12 months. If a physician tells a family, your parents or your child will live up to 12 months, it is the same as if we would say to 8 months or to 15 months or to 20 months. It's not based on anything. But 6 months, there are diseases that we know statistically that it makes sense. Now, there is a distinction between withholding and withdrawing. Halachically, it is kum v'aseh and shev ve'al ta'aseh. Shev ve'al ta'aseh is withholding. You just don't do anything and the person dies from his disease. Kum v'aseh, you do an act which hastens death. Now, halachically, it doesn't matter if the act that hastens death is what we call today active euthanasia, which is to inject a little dose of a medication that kills the person right away, or through a physician-assisted suicide, that the patient uses lethal medication, but he does it himself, not that the physician is doing it, but the physician prescribes it, or withdrawing something which at the act of withdrawal will kill the patient. All are one and the same. It is a kum v'aseh, it is an act of killing, and all are forbidden. As opposed to situations where I just don't interfere, and the process of dying is continuing without my direct act. And that is distinguished between a continuous and an intermittent form of treatment. Again, Shlomo Zalman Auerbach made very clear order on that. And intermittent treatment means that the treatment per se has pauses which are part of the treatment. So for instance, dialysis, you invite a patient Sunday morning, you hook him up to the dialysis machine for 4 hours, let's say. You take him off the machine as part of the treatment. You're not hastening his death. That's how you treat him. And after 2 days, he comes back for another unit of treatment. Each unit of this kind is a separate unit, and therefore you can withhold the next unit. And if you come to think about it, almost all treatments in end-of-life situations are of this kind. Antibiotics, chemotherapy, radiotherapy, surgeries, everything is periodic. You do the act is finishing, and if you don't repeat it, then it's a shev ve'al ta'aseh. There are just very few treatments that are continuous. One of them is a respirator. Obviously, someone who is in need of a respirator, you can't invite him for 4 hours on Sunday and hook him up to the respirator, take him off, and call him on Tuesday to come back. He obviously will never come back because it is a continuous type of treatment. And the other example is a cardiac pacemaker that also works permanently. If you stop it, the patient will die because this is an act of stopping a continuous treatment. And the last distinctive feature is the distinction between treatments that are pertaining to life, whereas those who are pertaining to the disease. In other words, there are treatments that because the person is dying and has a lethal disease, you need to give him this treatment. So if he has cancer, you need to give him chemotherapy. If he has renal failure, you need to give him dialysis. But there are treatments that we give to the dying patient that are unrelated to the fact that he is dying, because a non-dying patient will need the same thing. So for instance, food and fluid and oxygen, every one of us needs it whether we are dying or not. So that is not pertaining to the dying situation, and that cannot be even withheld, as opposed to those treatments pertaining to the disease that can be withheld unless they are continuous, and then it is a withdrawal and it's not allowed. So these are briefly the concepts of treatment. So as I said, there is a cyclic treatment where there is a clear separation between cycles of treatment, and a continuous treatment, which by nature of treatment is continuous. Now, if we come to philosophy, and that is an introduction to what we are going to talk about, the ventilator, so there are actually two opposing values in such a situation. They may coincide and they may go together, but they may be contradictory. One is the value of life, which means, in principle, that every minute of life has a value. So if we take this value as an absolute value, and in philosophy, absolute means that there are no exceptions to the rule, because once you find an exception, it becomes relative to this exception. So there are no exceptions. And if we would define the value of life as of absolute value, then no matter what, continuous, not continuous, pertaining, not pertaining, you have to do everything possible to prolong every minute of life. There are no options. But most of the poskim and most of the philosophers do not view the value of life as of an absolute value. They view it as an extremely important value. But still there may be exceptions. And therefore, it is not an absolute value on the one hand, but it is very important, and therefore you can never hasten death, but there's no requirement to always prolong life. And hence, if the patient is suffering, or he doesn't want to be continuing life, or there's another reason why not to do it, you can weigh it as a reason to let the patient die. Now, from a halachic point of view, there are many sources to point to the fact that indeed life is not of an absolute value. The mere fact that wars are allowed by the Torah means that life is not an absolute value, because if I'm called as a soldier to go to a dangerous place, I'll get a zettel from my rabbi. My life is of absolute value. I can't go there because I'm endangering my life. And how can you conduct a war if everyone will say that his life is of absolute value? We have capital punishment and many other sources. And we have the story of Yehuda Anossi, that the servant, the female servant, decided to let him die and to withhold further treatment, quote unquote, which was prayer. And indeed he died. And the halacha is like the servant. So you see that if life would have been of absolute value, we wouldn't listen to her. We would continue his prayer. And the same holds true for the value of autonomy. If I come as a patient and I say, I'm sick and tired of my life, I want you to kill me, that's my autonomous wish. Why don't you do it? If autonomy is the overriding principle, you should listen to me. And indeed, there are countries like this country here in Canada and others before, like the Netherlands, Belgium, certain parts of Australia. These are countries which take autonomy as an almost absolute value, And hence, if a patient is dying and says, I don't want this life anymore, I want to die now, but he won't die from his disease now, he will die in 2 weeks or in a month, in order for him to die now, or in order for us to fulfill his autonomous wish, I have to shoot him. But in hospitals, usually we don't go with pistols, so we inject certain medication that kills him. So that is absolutely unacceptable halachically. Autonomy is important, but not absolute, and therefore we can override an autonomous wish if it is in contradiction with other values that we think are more important. Okay, so to sum up, we distinguish between Chayei Olam and Chayei Sha'ah. In Chayei Sha'ah, it is permissible to withhold. It is forbidden to withdraw if it hastens death. And it is permissible to remove a hindrance in a way that will be a withholding process, even though it is part of the treatment. Now, when we come to a respirator, if we are talking about, if the patient has a Chayei Olam, he has a chance to survive, he has a chance to recover, and he can live more than, let's say, 12 months. In this case, there are no options to take him off the respirator and let him die, because he is Chayei Olam. Chayei Olam, we don't discuss at all. We are discussing about a patient who has Chayei Shor. No matter what we'll do, even if he will stay on the respirator, he will die within 12 months or 6 months, depending on the definition. He is suffering, and he is unwilling to continue with the respirator. Let's take the scenario which is the clearest. He is still conscious or competent, and he motions to us he doesn't want anymore the respirator. ALA patients and others can be fully conscious and communicate, and he says, I don't want, I'm suffering, this is bothering me, I want to die. And you are keeping me on the respirator against my will, and you are continuing my suffering by continuing my life. So from a secular point of view, it is fully accepted all over, not only in Canada, that in this case, a physician is permitted to withdraw the respirator and let the patient die, because they don't distinguish between kum v'aseh and sheval taseh. For them, it's one and the same, as long as this is what the patient wants, and I'm not injecting a lethal drug, that is okay. But halachically, since a respirator is a continuous form of treatment, and if I'll withdraw it, that will be an act that will hasten death. This I am not allowed to do. Because, as we said, it's an act of discontinuing a continuous treatment. So, if we stop here, once a patient is on a respirator, he's stuck. Now, what are the situations that this can happen? It can happen when the patient willingly accepted to be put on a respirator. Let's say he underwent surgery, and for the surgery he was put on a respirator, and there were complications, and now if we would have asked him on this condition whether he wants to be intubated, he would say no. But he's already on a respirator willingly, because he was put on a respirator to begin with in accordance with his wishes. Another situation can be that indeed he didn't want to be on a respirator, but it was an emergency. Hatzole or Mada or whoever came to his house, saw that he's not breathing, automatically intubated him. They don't ask questions, because they don't have the time and the know-how to decide if yes or not to put him on a respirator. He's an unknown patient to them. What they see is either they do it right away or he dies, so they have no option. So they put him on a respirator, they bring him to the hospital, and it turns out that he has a living will saying, I don't want to be put on a respirator, but he is now already on a respirator. What do you do? Or someone who was put on a respirator legitimately, but its condition worsened. And if you would ask him now, he would say no, but now he's already on a respirator. So these are very tragic and complicated situations. What do you do in this case? So here are some of the options that are still ways, halachically acceptable, some by all, some not by all, that we can stop the respirator under certain conditions. The best way is if legitimately we are weaning the patient from the respirator. Let's say he's now 20 days on the respirator, he's doing better, his pneumonia, his cancer, whatever, stabilized, and we are considering to weaning him from the respirator as a medical procedure, which we do all the time to people that we don't expect them to die, right? So we're weaning him off the respirator because we assess that if we'll take him off the respirator, he will be able to survive without the respirator. In this case, if it was done legitimately, and it's very tricky because many physicians that know this option say, yes, we think we can wean him, although they are sure that they can't. But I'm talking about purely halachically speaking, if it's an honest physician, we discuss with him, and he says, yes, he's stable, you can wean him. Weaning means gradually reducing the parameters of the respirator. The patient is still stable. We take him off the respirator. Now, 10 minutes later, he crashes. What do we do now? If we would discuss him now without knowing that he was on a respirator, in his situation now, we can withhold the respirator. But knowing that he was on a respirator and he was weaned and he crashed after 10 minutes, it means that either our assessment was wrong that we couldn't wean him, or we tried to wean him by all means, but it turned out not to be possible. So according to Shlomo Zalman Auerbach, in such a situation, if the patient holds out 24 hours without the respirator, even if after 24 hours there is again a worsening of his condition and now he requires a respirator, we allow not to put him back on the respirator. I asked him, why 24 hours? What about 12 hours? So he said, there are no sources to discuss the timing. It's just a matter of shikul hadas. His assessment is that he really stabilized when we weaned him after up to 24 hours. But he thought that 12 hours would also be acceptable. If he is stable and only after 12 hours he deteriorates, you don't have to put him on. Less than that, according to Shlomo Zalman, you have to put back the respirator. That is a matter of svara, as I said. There's no source to give these timings, but Shlomo Zalman is an authority. That is what he thought. Rabbi Osher Weiss disagrees, and he says any time that he was stable, it's sufficient to make a decision not to put him back. Now, any time, I don't think that he means a minute or two, and again, it's a matter of assessment, but it's not clear from him if there's a minimum for the time. But I'm presenting to you what I heard from Shlomo Zalman Auerbach. Another option is to turn the respirator from a continuous form of treatment to an intermittent form, to a cyclic form. And that is, for instance, in the old days, by the way, that happened all the time. When oxygen didn't come from the wall and was constantly available, respirators were connected to a tank of oxygen, and once the tank was exhausted, there was no oxygen, we switched the tank to a fuller tank, like we do with a barbecue and a gas balloon. The gas finishes, we replace it with a new gas. So in those days, everyone agreed that if the oxygen in the tank was finished, you don't need to replace it if there is an indication not to put him on now. If he wouldn't be on the respirator, and now you wouldn't put him on a respirator, but he is on a respirator and the tank is finished, then you don't have to replace it. It's a withholding process that you're not doing an act to continue. But nowadays, everything comes from the wall, so there's no minute that there's no oxygen in the machine. So one way is to take the machine off the oxygen from the wall, attach it to a tank, like we do, for instance, if we move the patient to X-ray or to a certain treatment. We don't schlep the wall with him in order to get the oxygen with him to the X-ray machine. So we put him on a tank. So we leave him on a tank. And if the tank is finished, we are not obligated to replace it. Another option, which I'll speak separately, is to adjust a timer a priori to the respirator, and I'll explain in a minute. A fourth option, again, that was Rav Shlomo Zalman Auerbach's position, is that if the patient is indeed dying and suffering, and if he wouldn't be on a respirator, we wouldn't put him on a respirator, would be allowed to withhold the respirator, is now that he is on a respirator, to reduce the parameters of the respirator to a level that he is still stable at the moment, knowing very well that with time there will be complications and he'll need higher parameters, but there is no obligation to raise the parameters, and then he will die on the respirator. We didn't remove the respirator, and yet he dies. There was an interesting story. Once, it was a known story. So I can mention names. It was President Navon, who was one of the presidents of Israel. His wife was very sick. She had metastatic breast cancer. She suffered terribly. In those days, palliative medicine wasn't so advanced. She was in an intensive care unit at Hadassah on a respirator, and she continued to live because she got the best treatment. The wife of the president obviously gets best treatment. The president turned to the doctors and he said, I don't want my wife to suffer anymore, but I don't want to do anything against halacha. Find me a solution. They didn't know what to tell him. If it's not against halacha, she has to be on a respirator. If she has to be on a respirator, she continues to suffer. There's no way out. They asked me if I have any idea, and I said, I don't know. So I went to Shlomo Zalman, I told him this story, and he said, how much oxygen are you breathing right now? So let's say in Yerushalayim maybe 19%, maybe 20%, 21%. He said, why does she need 100%? Reduce it to 20%. And the same with all the parameters, with the PEEP and everything. She doesn't need a maximum treatment. She's going to die. She needs to be on a respirator. We can't remove, but we can reduce the parameters. And they reduced the parameters, and within 24 hours, she died. So I came to Shlomo Zalman and I said, that's a tremendous chiddush, very important to so many people who are on respirators, suffering, and no one knows how to handle it, how to finish it. May I publish in your name that this is an option? So he said no. Why? Because he said, this is my chiddush. I don't know if any of the Gedolim would agree with me. I am firm with my opinion. Next time you have such a patient and you'll come to ask me, I'll tell you to do the same. But for publishing, I don't want to be the only one that does it. So I said, what will take that you would agree? I insisted because I thought it's a very important tool. So he said, if any of the other Gdolim will agree, I'll consider. So I knew that if I'll go to Rav Elyashiv, the answer will be no. Rav Elyashiv, everything new is no. So there was no point to go to him. So I went to Rav Wosner, who was certainly one of the greatest poskim, and I told him what happened and what Shlomo Zalman paskened. So he said, I agree with Rav Shlomo Zalman except for one point. And the point is that if you reduce the parameters, you have to do it gradually. Because if you reduce it at once, this by itself may hasten death. So if she is getting 100%, try 80%, wait, see what happens. If she is stable, go down to 60, and so on. And once she's unstable, stay at that level. So I went back to Shlomo Zalman, and I told him that I went to Rav Wosner, and he was very interested to know what he said. I said what he said, that he agrees with you except for this. So he said, you see, I was right that I didn't let you publish, because he's right. If you would have published the way I told you, that would be wrong. I didn't think about it, and he's right. So I said, okay, so now can I publish it? He said, absolutely, publish in his name. But finally, he agreed to be published. I published it in both names. And actually, we are using it at Shaarei Tzedek, not very frequently, but in special occasions, we are using this method. Now, there are two debatable options which we don't use. One is that, by definition, a respirator has to be stopped occasionally for suctioning, because there is accumulation of mucus and you have to suction. So if you stop it for suctioning, maybe you don't have to reconnect it at the time. But that wasn't acceptable by Reb Shlomo Zalman, because he said that is not like a dialysis machine that you really stop for a day, for 2 days. It's clear that you stop. Here, it's part of the treatment. It's not really stopping the respirator, it's part of the treatment. And the other one that Rav Zalman Nehemiah Goldberg, the son-in-law of Shlomo Zalman, agreed, but many disagreed with him, and that is in special occasions when there is a shortage of respirators, like it was in the COVID period. So let's say someone is on a respirator because we thought that it will save him, but he is deteriorating, he's going to die anyway, even though he's on a respirator, and now comes a new patient that needs a respirator and has greater chances to survive if he gets the respirator, but we have no machines. So instead of the two dying, one is on a respirator dying, and one is dying because he doesn't have a respirator, said of Zalman Nehemiah, you can remove the respirator from the one who doesn't have chances anymore in order to save someone who will have chances. So that is not in order to hasten his death just because we don't want him to live. It is in order of pikuach nefesh to save someone else. But most poskim disagreed, because the act of killing of this patient is still forbidden even if it's done for a pikuach nefesh of someone else. So that's debatable. So now let me just describe to you the issue with the timer. The concept of the timer was introduced in a committee that I chaired to legislate the Dying Patient Act in Israel. And everyone obviously was very worried that by law in Israel it will follow the halacha that you can't stop a respirator, which is different than any other country in the world. What will we do with so many patients who are stuck on the machines and they don't want it, but we can't stop it? So the idea came up to put a timer on the ventilator, meaning before you hook up the patient to the ventilator, you put a timer on the ventilator. Let's say you set it up for 5 days. And if within 5 days the patient is doing better, so you stop the timer and it will continue. If the patient is doing worse, or there's no point to continue, then the timer will automatically stop the respirator. Won't be a main act, won't be a withdrawal. It will be part of how the machine works. The machine, lechatchila, works this way. And Vardit Ravitsky, who was a member of our committee, published it in the BMJ. We got mixed, as obviously everything new, you get mixed comments. Some were very happy with it. Some thought it's just a trick. And there were all kinds of remarks. But what is the concept? So the timer enables doctors to honor the wishes of patients and families without termination of continuous treatment of a dying patient, which may cause death. In other words, this is not a direct act that hastens death. That is an indirect act, which is a built-in situation in the machine, similar to the oxygen tank, which is finishing, and you don't replace it. So the timer is finishing the acts of the machine, and you don't replace it. Same concept. And therefore, we thought this would be permissible. So it is like a Shabbos clock in principle. What do? I assume everyone, or at least most of us, every Friday, we set up the clock for the lights on Shabbos, and then on Shabbos, there are acts which we are not allowed to do. We can't put on or put off the light on Shabbos, but we instigated that it will go on and off by putting a timer when it was allowed to do it, on Friday, right? So a priori, we set the timer, and then the melocha, the thing that is forbidden to be done, is done automatically, and that is accepted almost by everyone. The only one who didn't accept it was Moshe Feinstein, and he said that if he would have lived at the time where such a Shabbos clock was introduced, he would have answered it. But since it's so frequently encountered and everyone agrees, he doesn't want to say anything. But most poskim really accept it as something that is lechatchila mutar. So that is the same concept with the timer. You put it at a time where it doesn't do anything wrong, when you just intubate the patient. And once it's going into action, it's done automatically, you didn't do anything, and the respirator stopped. And that concept was accepted by several poskim. Not all agree, like any new thing, you'll never find something that everyone agrees, but at least some of the leading poskim agreed. So the first one to agree to it was Rabbi Waldenberg, and that was many years before our time of ventilators and timers, and he really was talking about a real Shabbos clock. You take a regular, in the old days, a Shabbos clock was a clock that was a string attached to the switch, and when it rang, it pushed the swing and it closed the light. That is how it used to be, not like nowadays that everything is electrically controlled. So the Director General of Shaare Tzedek Hospital, Professor David Meir, just anecdotally, he was a pathologist in Einstein. And when the previous director of Shaare Tzedek passed away, he was elected to become the Director General of the hospital. Rav Waldenberg was the in-house poisek of Shaare Tzedek. He lived across the street, and there was a very good contact with him all the time. And he wasn't consulted about this appointment. And he got very angry. How come you appoint a pathologist to a Frum hospital? A pathologist does daily forbidden acts. He is dissecting bodies, which is not allowed. And he will become the director of the hospital, which Rabbi Waldenberg, are in charge of the halachas there. So he got very angry, and he stopped coming to the hospital. But with time, he realized that he was a very ehrlich Yid. He didn't do really autopsies. He just did pathological specimens. He was okay. And he was very close to him. And with time, they became friends. And David Mayer sent him this question. And he told him, you know, there's a problem with people on a respirator. How do we get rid of it? And I, David Mayer, suggest to put a Shabbos clock on the respirator. And he answered at length that that's okay. You can do it. There's an intrinsic contradiction between his positions. I won't go into it. I asked him, I never got an answer, but he felt that that would be okay. The same is Moshe Sternbuch, who is still with us. He is the Gaivet of the Eida Haredit. A big, big poisek, has thousands of tshuvas called Tshuvot Vanagot. And in one of them, he writes that he heard about such a concept of a timer on a respirator, and he thinks it's okay. So that was his psak. And a shaila that I wrote to Rabbi Zilberstein. Rabbi Zilberstein is the son-in-law of Rabbi Yashiv, and he is a major poisek in Bnei Brak, especially on medical halachic issues. And I asked him about a newborn baby after a preemie, 25th week of pregnancy, underwent full resuscitation. Can we attach a timer on his respirator, because such a preemie, his chances to survive are slim, and then even if he survives, there are many, many problems with him. Would it be permissible? And he answered, can't see it, but anyway, he answered it's okay to do it. And the next one was Rabbi Neuwirth, the author of Shmirat Shabbat K'ilchata. Dr. Halperin asked him about this situation, and he also allowed to put the timer on a respirator. So we have at least several major poskim who thought that this would be an appropriate way. Okay, now, just to finish up, there is no such timer. It doesn't exist. And the reason that it doesn't exist is that we did a prototype on a respirator with a dowel, connecting the respirator to a dowel that is breathing, putting the respirator, and it worked very well. Meaning that it stopped when we wanted it to stop, and more importantly, it didn't stop at the time that it didn't want to, because that would be killing the patient before the time, and maybe he has chances to survive. So the timer has to be very accurate. Now, what's the problem? To put a Shabbos clock on such a respirator won't work, because the respirators are built in a system that when there is a shortage of electricity, it kicks in. Because imagine a regular timer, and something happens, there's no electricity, all the patients will die. So the respirator is independent. You can't stop it just because you circumvent the circuit. So if you put a regular Shabbos clock, and it will pull the plug, pull the switch, it will automatically restart. So you need something that is more sophisticated, that can circumvent the process of the ventilator to save itself. So that's a more complicated machinery. Secondly, we don't want it, let's say we put a timer for 5 days. We don't want that in 5 days it will stop. Maybe something happened, maybe there's still something to do, maybe there should be a chance for it. So the idea was 12 hours before the time set, it will ring, it won't stop, we'll reassess the situation of the patient, of his wishes, and so on. And only if we are sure that we can go on, then we'll restart the timer and then it will go into effect. So it's complicated. So this worked well on a doll. But it's a new device. A new device needs an IRB approval, right? You need to do testings. You need to make sure that it's all okay. Now, in order to test it on a patient, you need his informed consent. It's a regular experiment. It's a medical experiment that you need informed consent. Most, if not all, intubated patients in an ICU can't give consent. They are unconscious, they can't talk, they don't understand. How can you get the informed consent? So we broke our head for a long time, and finally there were incidentally 2 patients that were awake, alert, intubated, and we could talk to them. And they agreed. So we did an experiment on these 2, and on both something was wrong. Not to the degree that it killed them, but something was wrong. So the IRB said, you have to fix it. So we went back, we fixed it. But now we couldn't find anyone that can consent on the new machine. So at the moment, we don't have a machine because we can't get a consent. The other, and I'll finish by that, the other incident happened during COVID. As you know, at the beginning of COVID, no one was prepared. And there were many, many patients who needed an ICU bed and respirators. And in Israel, there was a fear that there won't be enough respirators for so many patients. So they bought, 2,000 machines from all over the world, which are still lying somewhere wasted because they bought quickly, not checking, just to have it. And 2 companies in Israel started to produce respirators. So I told the Minister of Health at the time, that is an opportunity that the company will build in, not an outside timer. Part of the technology of the respirator will be a timer. Because in Israel, we are interested. A company that does respirators in the United States doesn't care for it, because in the United States, you can pull the plug. So what do they need a timer? But here, it should work. So we looked into this option. And it turned out, I don't know why, I don't understand it, but it was very expensive to add this technological device. And because it was so expensive, and there were many expenses with the COVID pandemic, that the Ministry of Health didn't like the idea, and to this day, we don't have it. But if we'll have it, I think that could be a good solution. Thank you.
Do the same rules apply for a family member to make the consents or what?
Well,
You kind of skirted that.
It could be, but the IRB wasn't happy. They said this is a very new...
Not just for that technology, but for everything you
No,
talk
for
about.
other things, obviously, it's not really a consent by family. It is an agreement or discussion because they can't replace the patient. When does a family replace? If you need to do something to save the patient, and you can't do it because you don't have the consent, the patient can't cooperate. Then there are various levels on how to decide what to do. And family can be one of these, but not when you do an experiment. It's not for the treatment.
Yeah. No, but as well as doing something to save a patient, but doing one of the things you talked about.
Sure.
It works with the
Yeah,
same rules
but family
apply.
is a problematic method because who is the family? Is it the wife? Is it the son? Is it the brother?
What's the
and what if
hierarchy?
they disagree with each other? And who decides? So you can talk about an appointed surrogate, appointed by court. Who says that he really knows what the patient would want? A lot of ethical questions in that.
Yeah,
but not in an experiment. In an
I
experiment,
understand that.
you don't do it.
No, we have an established hierarchy as to
Right.
who is
Yeah,
the...
maybe you'll talk about the hierarchy in a living will.
Two questions. One is about decreasing the parameters on the ventilator. And I just want to make sure I heard correctly. So sometimes we can decrease the parameters and the patient's stable for 5 minutes or 5 hours, but sometimes we decrease it right away. You see the O2 sat is dropping, let's say. And what I thought you said was that to hold it at that level, or do we have to return it to the previous level?
No, you reduce it to a level that the patient is still stable.
Right.
Once he's stable, you leave it at that level, and if later he becomes unstable, you don't have to increase it back to what it was.
Right, but stable could be measured just vital signs, or we could decrease.
Yeah,
or
just
it could be a
vital
blood gas an hour later.
No, in dying patients, usually we don't take blood gases, and this. It's useless. What for? You want them,
Right,
you
that's
want
what
them
I
to die.
understand.
You don't want to correct everything.
So just to be concrete about it, patients on 100% O2 on the ventilator, and we decrease them to 90% or 85%, and suddenly it starts dropping. We have to put them back up again?
If it's within 12 hours, yes. If 12 hours he was stable, everything was okay, then if now he deteriorates, you don't have to.
So the 12-hour rule would apply for the ventilator changes also, not just
Right,
extubation?
exactly.
Okay, the other question was about the suctioning, whether that's considered cyclic, whether one could just skip suctioning. In
Could
other
one-
words, patients need suctioning
Right.
because it impedes airflow, et cetera. Wouldn't that be like a cyclic type of treatment that one could skip the suctioning, let the patient die?
No, so because this is the form of treatment, it's like stopping the oxygen for 50 minutes and then let the patient suffocate. That is not allowed because this is almost as an act of killing. You are drowning him in his saliva. That
Got it,
most
okay.
poskim say this is part of the treatment and you have to continue it. But while you do it, he is not connected. Would that be a cyclic type of the treatment? That was the question.
And if let's say I decreased the parameters, I went off shift, is the next physician obligated, it's only 2 hours to turn everything back up again? Or
No, it doesn't matter about the shift. It matters on the timing. In Israel now, according to the law, there is one physician who is responsible for one patient. And all the decisions, day and night, Sunday or Monday, have to go through him. It's not everyone that comes on board makes a new calculation and a new discussion and a new decision. That is done today in Israel by one person from the beginning to the end.
And if I knew someone in the United States was going to take me over and would be willing to leave the patient.
Even longer. I mean, if he follows the Shlomo Zalman rules, then he should do the way as if you are still there, as it was decided.
A number of the cases you presented, the Halachic opinions were very specific. You know, so you went to the top guy, he gave you the Halachic decision. And the problem I see could be, where are these people? These decisions happen all the time. Somebody's in the ICU and is unstable or stable now and they're not going to be stable, something's going to happen. You know, they happen all the time. Are the poskim in the hospital to make decisions? You know, these come up all the time and people have to make decisions. And it seems to me that a lot of decisions that you say, well, this guy says this and this guy says that, you're left in, it could be, you know, make up an opinion. You know, I'm going to follow this opinion. It depends on what my training is. There's nothing specific. So I wonder if you could address that.
No, I mean, that's how halacha, and by the way, medicine works. If you are on call and you spoke to your attending and he told you one thing, if would be a different attending, he would tell you a different thing. And now that he told you he's not there anymore and something happens, what do? It's a matter of understanding the principles and acting accordingly. What I try to show you is what principles have been accepted by some of the poskim. It's not to say that everyone would agree. Maybe you'll ask a different posek, he'll tell you he doesn't agree to it. I don't know, I'm saying. But I'm presenting to you principles. And you have to act daily according to the the principles, like in medicine. You learned once how to treat streptococcal pneumonia, and you don't ask every day if the streptococcus is of this kind or that kind. What do? You do what you learned that you know how to do. But you need to know the parameters of what you can do. And that's what I try to point out.
I was curious about, you went to POSEC, two things. One gave an opinion that 24 hours of stability is okay, and then you said, what about 12? You said 12. And the other case was, let's cut from 100 to 20, and somebody else said 180. What I'm curious is, I understand POSEC would have the final word, but aren't these really medical judgments? Like how does a POSEC know you only need 12 or 24 hours to determine whether a patient is stable?
No, do you know medically which is better, 12 or 24 hours? Is it a medical question?
I think, like, if this happened in my family and we didn't go to the POSEC, I would know better than my family members that weren't
No,
physicians.
on this question.
On
Is
either of these
stability of 12 hours more a sign that it was stable than 24 hours, medically speaking? It's not a medical question.
I'm wondering why you went from 24 to 12. I think that's because you thought that was enough for stability,
Yeah,
based on your medical expertise.
But not because, no, I don't know
Based
any
on
medical
experience,
fact.
medical experience.
Do you know any medical fact that can answer this question?
It's
It's a matter of judgment of what is called stable. The stability is judged by the physician, not by the rabbi.
Right.
Whether he is stable in this 12 hours or 24 hours is the judgment of the physician because it's a medical question. But whether it's sufficient, 12, 15, 20, 24 hours, it's a matter of judgment. And you can accept, Rabbi Bach himself said that it's his judgment. It's not because there's a Gemara that says that this is what's called stable.
I'm
In
curious.
all these matters,
Yeah.
there is an issue of shikul hadat. There's nothing specifically written neither in medicine nor in halacha. It is a matter of shikul hadat. But what I'm trying to point to you is not the 12 or 24 hours, but the principle that reducing parameters is not equivalent to withdrawing the respirator. Sure. That is a principle.
Sure.
But the details, you can argue. I mean, it's a, but in medicine it's the same. Ask this expert, he'll tell you so, and ask another expert, he'll the opposite.
Why did you ask to go from 24 to 12? Why did
No,
you
I asked him why 24, and since he said that it's not something that is specific, I tried maybe less.
Thank you very much, Rabbi Steinberg. There will be plenty of time. We're in a small group over Shabbos. You'll have time to ask some of the more technical questions that pertain to each of the cases that you have. I want to move on. The next topic that we're going to be discussing is the halachic living will. So going back, this is not the topic that we're going to discuss, is the new approach. There has already been a halachic living will from the RCA. Being that this is a Canadian conference, I just want to point out that the Vada Rabbanim of Toronto put out a living will, which really is quite different than the one from the RCA. I'm stealing his thunder. I am sorry. Maybe I'll leave that then. Anyways, I didn't see your slides. So, without further ado, Rabbi Brody.
Okay. This is the first time it's being publicly discussed. It was designed by myself and my colleague, Rabbi Dr. Jason Weiner, as the senior chaplain of Cedars-Sinai Medical Center. And it is not to be used in Canada yet. So I just want to put that out there. The version you're seeing, think about it. But the second part, you'll see. The second part can be used anywhere in the world. We're going to be focusing on Chutz La'aretz and not in Israel, because Israel's different laws regulating this. And the reason why it's not usable yet in Canada is my Canadian legal advisors are still working out a little bit of the formulations, which are sensitive to Ontario law and Quebec law and this or that. Also, if you come from the great states of Ohio, New Hampshire, Wisconsin, and Texas, we still fiddling around with there because federalism has its downsides. But nonetheless, I want to show you the approach and give you a little bit of background of what we're trying to do. So this whole concept of a living will, right, is a matter or was a matter of dispute in rabbinic circles, and I want to show you a very fascinating debate between two of the major powerhouses of Jewish medical ethics in the 20th and beyond centuries, Rabbi Lord Emanuel Jacobovitz Zitzal and Rabbi Tendler Zitzal. And Rabbi Jacobovitz, he publishes in his book called Dear Chief Rabbi of Correspondence, he was very against this whole notion of saying that we're going to have a living will. What's a living will? So just as you leave a last will and testament about where your financial affairs should go, so too, while you are alive, you would create something which would talk about your will of what treatment should be due as you age or get sick and whatnot, including specific directives. And certainly the trend was in the 80s, of very specific directives. If I'm in X, Y, and Z situation, do X or don't do Y. And Rabbi Jacobovitz took an approach which says this whole notion of a living will is alien to Jewish thought and law, because the will of a Jew is to live. So the notion of saying that a living will, that we can have an option of choosing, relating to some of the questions of autonomy that Rabbi Steinberg was referencing to, Lord Jacobovitz was against this concept. And he was against it as a matter of principle, but he's also against it as a matter of the culture in which we live in. Whereas he was very much afraid that the wave of autonomy was going to take us in bad directions, and the will of a Jew should be to live. And so this whole notion of saying, I want X, Y, and Z, or I want you to make this decision for me, is inappropriate, because there's always one correct decision. Now, in contrast to that, you had Rabbi Tendler, and this is a debate that they have going on, right? Which Rabbi Tendler said that this concept will be halachically acceptable, but there has to be two conditions. A, procedures that can be withheld or withdrawn do not include hydration and nutrition. Now, it's relating to the questions that Professor Steinberg was mentioning beforehand. He was very much without, now, you'll see some of the things he specifies. It's not exactly the same list as of Shlomo Zalman Auerbach, which is a side conversation. But his point was saying that the options have to be limited to things within the realm of halacha. But if the options are limited to things that are permissible within halacha, this is an acceptable idea. And the second thing was that you find the requirement for the input of your attending physician. In a regular living will, you also should be doing this with regard to bringing in the posek as well for checks and balances. And in many ways, Rabbi Tendler's view on this won the day, but we'll see in what ways and how. And so Rabbi Tendler was the head of the Halachic Committee of the Rabbinical Council of America. And in 1991, the RCA put out what's a healthcare proxy and directive. Now let's make sure we understand the terms here, because it's important. You have a proxy, which is a form that appoints an agent. Now there might be defaults of who you would ask if you don't have a proxy, but part of the point of a proxy is for someone to say, I want this person to make the decisions in case when I am not available or not able to make decisions for myself. And there's a little bit of a discussion about this, but let's assume for our purposes that they'll make the decisions and what they think I would want in these cases, what's known as substituted judgment. Okay? Then you have a notion of advanced healthcare directive, which is not just appointing a proxy or durable power of attorney for healthcare purposes, but is also saying specific things. Well, I want X, Y, and Z done. I'm directing that to be done. And so Rabbi Tendler crafts this element here, which is an element of a healthcare proxy, and says, I hereby appoint this person to be my agent. Note, he gives an option as well to consult with halachic authority. And putting in this, of course, is once I bring in the healthcare authority, my agent is no longer able to make decisions about artificial nutrition and hydration. Well, who is? Answer, the rabbi. And then he goes on to say, I have an alternate. And then you get into a detailed directive. This is pretty wild. We have 4 different situations. If I can't read the print here, but I'll read it, some of it. If I am in a coma, or a persistent vegetative state, and in the opinion of my physician and several consultants, have no known hope of regaining awareness or higher mental functioning, no matter what is done, then my wishes regarding use of the following, if considered medically responsible, would be. And you see a list on the left, and you check, I want and I don't want. This is very, very detailed. The obvious problem with this, of course, is, does anyone filling out this document know what this is talking about? But this wasn't just a trend in the RCA document. This was a trend in many medical circles in general. We gave very specific scenarios, and we gave very specific treatments. You decide, do I want X, Y, or Z? Additionally, in this document of the RCA, there's a couple of issues here. Well, if there's a disagreement between what I just wrote on page 2 and my proxy, who do I want to win? And Rabbi Tendler put in, I also have the option of saying, yes, not just option, but sort of the default, I will donate organs. So you understand this is a loaded document on many different levels because Rabbi Tendler, of course, position was that respiratory brain death is a Halachic criterion for death, and therefore you can donate organs, and he pushed this through into the RCA proxy. When that happened at that time, at about the same time, the Aguda, the other major rabbinic group in the United States, put out their own proxy, and it's very interesting why. They made a number of declarations explaining why this would be, but they said that the likelihood is too great in such a situation that medical procedures will be performed and withheld in ways that constitute a violation of halacha. You're going to find yourself in the hospital, in the ER, the ICU, whatever it might be. We need to have an advanced statement that's prepared for your healthcare providers to understand what you'd want or wouldn't want. And of course, what we want is not specific matters at this stage, but follow halacha. And so the Aguda, at about the same time that the RCA puts out theirs, puts out 2 parts. One is a proxy. You appoint your competent adult to make the decisions. And the second is the directive. But the directive is, I want all decisions to be a shaila. And I want it to be, right, something where I designate a specific rabbi. Now, interestingly enough, in the original forms, they make clear they're not going to specify what it is that should or shouldn't be done, because that's difficult to know in difficult circumstances, and there are different shitot in the poskim. You are going to decide this with who your posek is, and those decisions are going to be made in consultation with your mora hara. So it's actually very interesting. In the original version of the Aguda Living Will, it's much more of a proxy, focused on appointing a proxy, and to have a general directive for people to understand you want to follow halacha. What's fascinating is the RCA proxy document basically fell by the wayside. And it fell by the wayside for a number of different reasons. Reason number one is the whole trend became to understand that that menu of options of I want or don't want isn't really practical. It's not practical so that people filling it out don't know what these terms mean. It's also not practical because you're running marathons and you're 55 and you're signing that document, and when you're 82 and the issues come up, your opinion might have changed along the way. Right? So how good is it to predict and say, I want X, Y, and Z, when you don't even know what X, Y, and Z mean, and of course your position might change. And the second issue is that the RCA document assumed that halacha permits organ donation, and since that became a big Labor Day discussion within RCA circles, that also made a problem, and therefore the RCA more or less moved in 2009 to the Aguda model. What's interesting is that the Aguda itself started to change their provision. Why? The Aguda, we said beforehand, initially had left it as very general. I want a shaila. But as healthcare trends changed, remember the famous cases of healthcare in the United States in particular, but other places as well, is where the doctors were insisting on continuing treatment and the family of the patient was saying, right, withdraw or stop. That was the initial fights. Then the trend, of course, has flipped, right? So where you have cases where the hospitals have no problem of stopping treatment in one form or another, and the family wants something to be done. And so the Aguda said, we need to create a document which starts to make it very clear, right, that without 11 way, the general default is, if I suffer cardiac or respiratory arrest, we'll see a couple of examples of this momentarily. I'll go back, sorry, right? Then we want these things to be done, unless my rabbi or agent says otherwise. Okay, so if you take a look at the formulation here, it's actually interesting. In the Aguda text as follows. I direct my agent to consult with the following Orthodox rabbi, and I ask my agent to follow his guidance. Any lawyers in the room? Even if you're not a lawyer, let's think this through. Think in a lawyerly cup right now. Who's the agent? Is it your agent, or is it your rabbi? Meaning, if you're telling your shaliach to tell the shaliach, right, who's the shaliach? So who's the agent here? There are cases in New Jersey where the hospitals insisted that the rabbi come down and sign the paper as well, because they said, we don't know what this document is doing in terms of who it's appointing. But the other question that comes is, take a look at a recent edition. I understand totally where this is coming from, but think about this formulation. This is in the living will that is used today. I am aware that there may come a time when I'm asked to reconsider, sorry, let's start from the beginning. I'm making a request to medical providers. I have made a decision set forth in this document, particularly those stating that I want my healthcare decisions made by a healthcare agent, in accordance with Orthodox Jewish law and consultation with Orthodox rabbi, after a great deal of thought, and in view of my very deeply held religious beliefs. I am aware that there may come a time when I'm asked to reconsider these decisions. In other words, the document is anticipating. The hospital is going to say, you really want this to be done to you? Do you really want resuscitation here? And I'm telling you now, don't ask me that in a way that's going to try to persuade me in A to vary from the position I've said here. And if you're going to ask me about it, only do it when my proxy and hopefully also my rabbi are around. What's that Gouda trying to do? To preempt the conversation. We really, really, really do not want any life-sustaining treatments to be stopped in any way unless we initiate it and unless the proxy or the posek or Orthodox Jewish law allows it. So this is the existing document, and I'm not being critical by this in any means. What I mean is they understand they have a certain vision of what it means to deal with hospitals today. And the vision is that the hospitals are going to try to stop treatment, and the default in halacha is to always keep treatment going, and therefore you create a legal text which tries to buttress that position from the get-go. So when you show up in the hospital, what do you have? A directive which already says, I have a proxy, I have a posek, I have halacha, this is what should be done. Now, if you look at the Ontario model, which we were talking about, the ladies were talking about earlier, which is being disseminated, I guess, during COVID in particular, so here it even gets a little bit, relates a little bit more to what we talked about last night as well, where it says, listen, I'm Jewish and I have rights under the Canadian law and under the Charter of Rights and Freedoms. And I decide with these rights that my health care should be done according to strict Orthodox Jewish interpretation, and tradition should any uncertainty arise as to my wishes. I fully subscribe to the values and beliefs of Judaism, that every moment of life is of infinite value. I therefore direct that unless determined by a rabbinic advisor, my life be prolonged for as long as possible by any means medically available. And then it goes on to say, I wish to always receive all possible life-sustaining health care to sustain my life for as long as possible. And this I direct, right? For further clarity, you ask, but this includes anything serious, life expectancy, unless my rabbinic advisor says otherwise. Okay, so this is an approach. We've moved away from the RCA approach, the original 1991 approach, which says detail things in great amount of level, make those decisions, which I totally agree with, which is the trend in the medical world as well. But part of what the Aguda model, the Chaim Aruchim, which is part of the Aguda model right now, is to try to promote a vision which says that we have to go in on the assumption that there's going to be some form of combative discourse, if you will, between the hospital and the Orthodox Jewish patient, and we want to make very clear that either the proxy or the rabbi is going to make the decisions here and let people know that we want everything to be done unless told otherwise. Now, this is a totally fine model if you agree that every moment of life is of infinite value, which is Jewish value. And if you agree, right, that your decisions should be either made by your proxy or your posek or this general thing, right? The question is this work? One second. The question is, does it work on a couple of different levels? On a legal level, it's an interesting question, which has to be tested, right, in court. Is this an actual clear proxy directive? Because I've spoken now to, again, I'm not being critical of it, because everyone's trying to experiment here. I've spoken to 4 lawyers in 4 different countries, Western countries around the world, who say to me, this is not a clear proxy designation. Who's the proxy here? Is it the family member, or whoever else you decide to be? Is it the rabbi, which again, I understand why they want to do that. Or is it that you just want to follow halacha, whatever that might be? Now, in this model at least, they tell you what halacha means. I value every moment of life as of infinite value, and keep me going in any way possible unless you say X, Y, and Z. So that's a model, and it's certainly a legitimate model, and people can use it. Now, when we started to think about Embatai, well, can we create a different model that will be usable? So we started to ask, on the one hand, we very much don't want to go back to this. This doesn't make a whole lot of sense anymore. No one's doing that today. Meaning, I should say no one, but the general trend today is that this doesn't make a lot of sense because there have been many studies in the medical world, right, who have shown that these advanced directives don't help too much. People's minds change, scenarios come up, people don't understand what this means, and therefore this is being shelved in a lot of different ways. Not always, right? There are definitely people who promote, there's the 5 Wishes Project, there are different types of programs. You can find these documents online. The Conversation Project, the 5 Wishes, which will sometimes have an advanced directive like this, but at least about some issues, but not as much. The second question which we were concerned with is, on the one hand, we really want our healthcare to be done by halacha. On the other hand, what exactly does that mean? Halacha is worked on a case-by-case basis. We have different patients in front of us, different scenarios, the different wishes can be, right? Some things we were just talking about. So how can you write a directive like this if in practice it's a lot more nuanced? The other problem is that when people raised us and the doctors, we talked about this formulation, the doctor said to us, what you're setting up here is for a confrontation model. You're assuming that they're going to want to kill you, and we want to keep alive, and how you go walk in the hospital, and that's how the whole discourse is going to begin. That's not a very healthy way to start a dialogue. And so what we've been working on for the last sort of year is something in which we try to help people figure out the netivot. We don't know what pathways we're going to go in life. Let's set you up in a way that will help you prepare for the different types of contingencies that we cannot predict. Because no one knows where the healthcare journey is going to take them on. But we want to have in place something which helps protect you in the following sense. A, on a legal level, that clarifies who should make these decisions. And B, that helps facilitate an informed decision-making within your family. So let's take a look, if we can, at the document that's in front of you. Now, there are 2 different parts to this. Okay. Obviously, there's some instructions here, but I'm explaining to the outside. The first part, which you'll see here on what's known as page 4 here, is very simple. Oh, by the way, I happen to think that aesthetically, this looks a lot better than this. Right? So obviously, we work with a graphic designer. We work with a graphic designer in order to do this properly, and in color schemes. We're also the only Jewish organization that seems not to use the color blue, which I'm very proud of. But in any case, although I love the color blue, but in any case, we try to make this super simple, following the models that we see in general society. You put your personal information, you choose your proxy and alternates. Why do you need an alternate? Sometimes your proxy isn't available. Sometimes the proxy is in Peru. sometimes all sorts of things. And you have three different options. Should you put down your spouse? Well, if you're 50, maybe you should put down your spouse, is number one. If you're, 80, maybe not, right? You have to depend on that. You got to think that through. It's a careful choice you have to make. Who do you want to be the proxy? And I have all sorts of fascinating conversations with people when they ask me, which of my kids should I appoint? Right? I don't know. So some, like the lawyers can draw up for you if you have 4 kids. So the first 2 years, who's going to make the decision? So they wanted to make it to be, well, it'll be a vote. But it's only 4 kids. How do you decide to vote? So if in the next 2 years something happens, the oldest kid has the deciding vote. And if it happens from 3 to 4 years, number 2. This doesn't make any sense. Right? You got to decide within the family, and you have to have open conversations with your family. I want this person to make these decisions, not the other one. That's an interesting family dynamic. Sometimes, but at the end of the day, if you don't appoint a proxy, what's going to happen in that interesting family dynamic when you have an acute crisis? So by not taking care of this now, what are you doing? You're setting up your family for a very uncomfortable conversation. So clarify it from the get-go. Part number 2, after you do the proxy, by the way, and it's so funny when people tell me, I had this one person tell me, I got 4 kids, 3 are from, 1 isn't. So I said, which one do you appoint as the proxy? Answer? The not from one. So why the not from one? He says, because he'll do whatever I want. And the from one's going to start talking to the rabbi, this or that. So this is interesting. So I said to them, well, why would you go to your rabbi? There's a from person I was talking to. So they said to me, I'm afraid that the rabbi is going to cause me or my family member to suffer. Well, I care about halacha. I don't want that to happen. And I said to him, that's terrible. Why do you think that about rabbis? And he said to me, because I know X, Y, and Z stories. So I said to him, b'vakasha. That's why I have an organization that's very transparent of our values, working with mainstream poskim who care very much about the sanctity of life and standing up for the sanctity of life, but also understand that quality of life and pain and suffering are values as well. You don't have to choose between, am I keep halacha or am I going to care about me suffering? It's a horrible thing. It's a horrible thing that people have this misimpression, which I understand this comes from somewhere. So that's part 1. The declaration. What are you saying in the declaration here? And this says in about 30 different ways, I only want my proxy to make these decisions. Why? Because in many circumstances, you can imagine a case where someone will try to remove the decision-making from the family and saying the family isn't doing what's in the best interest of the person could have anticipated this. And so our document tries to buttress on a legal level the standing of the proxy. This is why it matters which country you're in, because that's why we're concerned about formulating differently in Canada or in America or in UK we're working on this and whatnot. It also declares that I give authority, my desire, which I hereby direct my proxy, that all decision-making about healthcare should be done in accordance with the Jewish law and custom. Now, what does Jewish law and custom mean? Answer?
According to your rabbi.
No. According to your rabbi, wait a minute. Who's the rabbi?
I don't know, well, your proxy is you're asking your proxy to consult with your rabbi.
Who's your rabbi?
The guy on the form.
What do you say?
The guy on the form.
The guy on the form, meaning you decide. One of the biggest shilas that we all have to ask ourselves is who do we decide is our rabbi? Who do we decide is our posek? This is a decision you have to make in life. If you want to have, right? So don't leave it up to general Orthodox Jewish law. Decide who is your posek. Not an easy question for everyone to answer, and I'll tell you why. Let's say you've had your shul rabbis involved, or you've had a rabbi from childhood, you have 5 different kids, one's yeshivish, one's Haredi, one's Dati Leumi, one's Modernisha, one's not from. Who are they asking?
The not from one.
No. Who are they asking? The answer is they're all asking their own rabbis. Is that what you wanted? Maybe. Or decide. Make a decision. Who's going to be the rabbi that makes those decisions? It's a very, very important decision for people to make in life. mean, it's one of the Rabbi, if you were here earlier, so Rabbi Glatt was talking about Selach Harav, B'vakasha. This is the opportunity now to clarify for you and your family, who do you want to make decisions in these cases? It's not such an easy answer for some people, by the way. Some people are very close to certain rabbis, but they could also be close to a certain rabbi who they love for various reasons, but really have different feelings about, let's say, end-of-life care. Right? You could be, very close to a certain rabbi who you think is a wonderful darshan, wonderful about this, that, but you really have different issues on this thing. Are you going to choose him or not? That is one of the decisions you have to make in life. And we formulated it very carefully. As to the requirements of Jewish law and custom, I advise my proxy to consult with the following rabbi or religious institution. Why do we formulate it that way? Because we wanted to make it very clear on a legal level. Who's the proxy? The answer is the person you chose on page number 1. Now, if you want, you can choose your rabbi to be your proxy. Most rabbis I don't know don't want to be chosen as the proxy for a very simple reason. Unless they're your family member, they're not dropping everything on a regular basis to come down to the hospital. They can't do it. And so the rabbis don't typically, unless there's certain specific circumstances, want to be that. Now, remember we saw earlier that part of the reason why the RCA document fell was because of this, of organ donation. Now, I care a lot about the issue of organ donation. I think it's very important. It doesn't come up every day, but it's an important issue. I care a lot about it. I think it's an important issue. But I don't want to lose everyone on this issue, which is a Maisa B'chol Yom, that everyone has to deal with, over the issue of organ donation. And so Rabbi Weiner, when he created the document for Cedar Sinai Hospital in LA, came up with the following formulation. This section is relevant only if death as defined by Jewish law and custom has been determined by my agent in consultation with my named rabbinic consultant. I authorize my proxy to approve transplantation of any organs and tissues permissible under Jewish law and custom. Have you declared now that you're going to donate organs? Yes, but only if death has been determined by my agent in consultation with my named rabbinic consultant. Meaning it's a way for people to sign up and say, if we get to the point where there is death, according to the posek I've chosen, I want my organs to be donated. Now, I did this for a second reason. Not only to get rid of this problem of the whole debate, but for a second issue. Technology is changing. If you were here earlier, you heard me speak about this as well. It could be 10 years from now, 15 years from now, 20 years from now. There's going to be a lot more opportunities for organ donation even after cardiac death or circulatory death. In which case, why do I want people to sign up for a very specific type of death when other opportunities could exist? You can sign this document when you're 25. At the age of 50, 25 years from now, right, many opportunities could exist. And so we try to do it that way in order to get around some of these issues, anticipate the future. V'zeu. That's it. You sign it. 2 witnesses in 4 states in the United States. You have to have it notarized. And that is it, my friends. Simple document, legally binding, and we've set up with an organization, a company, you can have it digitally stored. So it can be accessed 24/7, 365 from anywhere in the world. Why is this important? Because this document ain't helping you if it's in your safe deposit. Yeah, don't put it in the safe deposit. Or don't put it in your, with your last will and testament. Your last will and testament they're looking at after you're dead. This is a document you want to be with you. Now, the problem with this model alone, which is very good, I think everyone over the age of 18 should have it. Over the age of 18, have this document, something set up, it protects them, helps it clarify a number of questions, but you haven't said anything to your loved ones about what your vision or personal preferences might be. Now, no one likes talking about our personal preferences about aging and end of life. Why? Because it makes us confront mortality, and no one likes to confront mortality. This isn't a Jewish thing, this is a general phenomenon and whatnot. However, if you don't speak about this at all, then how are they going to know when the moment of truth comes? So you're basically just kicking the decision down the butt, right? Kicking the bucket down the road. I've lived in Israel too long where all my English idioms are getting a little bit confused. But buckets, road, something like that, right? So you're pushing the decision to later and just leaving this for your family. But it's hard for people to have these conversations. And the conversations, by the way, aren't just about end-of-life decision-making. They're also about questions that can come up as people age and become more dependent on the help of their loved ones. And so we created a conversation guide. And this guide, which is a little bit of a different color scheme to separate it out, is not a legal document. It's not a legal document. It doesn't have to be signed, doesn't have to be sealed, doesn't have to be witnessed, but instead is a conversation guide that's meant to trigger conversations. How do you feel about pain, risk tolerance? Are there experiences you've had with death that you thought were good, that weren't good? Right? And there are a couple of halachically sensitive questions about if I'm deemed terminally ill, what types of treatments might I want, but this is not a directive. Why don't we make this a directive? Because people's minds change. And you don't know where your healthcare journey is going to take. So if that's the case, what's the point of the conversation? The answer is every conversation, especially the first one, makes the next one a lot easier to have. I'll give you an analogy. It's a crude analogy, but pardon it, but it makes the point. We all know that we should talk to our kids about the birds and the bees. When should we talk to our kids about the birds and the bees? When we can sit them down and talk to them about it properly in a mature way, or when we find them doing X, Y, and Z, wherever it might be. Answer is, makes a lot more sense to talk to them about it ahead of time properly, because the next conversation can be a lot more mature, informed, in a much more calmer manner. So the same thing is true when thinking about these issues. Trigger conversations, talk about some basic things. You don't have to write any answers here. There are boxes, there are scales. This is not a legally binding thing, it's not a directive. Now, there are other such documents that exist in the world today. They're not halachically sensitive. Meaning some of the options they give would be choices that wouldn't be appropriate, certainly as a default in halachic circumstances. And so we spend a lot of time working with rabbis and doctors and social workers and lawyers to formulate this in a way which will be a conversation guide. Now, this document, I don't think you have to sign when you're 18. Okay? But when you get to 50, maybe it's the first time, talk about your parents, talk about your loved one, whoever it might be. And every several years, right, you can, as your healthcare journey goes along, it becomes a lot easier to talk about these issues when you've talked about them beforehand. Baruch Hashem, the document now has the approval of Rabbi Willig and Rabbi Schechter. I've been very supportive of it in general. We're pushing with different organizations to get it out. And what I hope we're going to be able to accomplish here is to avoid some of the pitfalls of the many wonderful initiatives that have been taken by other organizations. I mean, Baruch Hashem, other organizations have set the tone, have made it stress the importance of it. And what we're trying now to do is to create something which we think works legally, right? Clarifies some of the critical questions that people have to decide. Who's going to make those decisions? Who's the rabbi you want that decision maker to talk to? That's a big decision. And to let the hospital and the healthcare providers know, Big Ado in general, this is how I see my healthcare should be guided by Jewish law and custom, which can be open to interpretation because there are differences of opinions about what that means in different circumstances. But that's why we empower the proxy. And then the second part is to open some conversations, because no one likes talking about mortality, but it's always, always, always going to be beneficial if you've talked about it a little bit. I'm going to tell you a couple of very sad stories. I hear about these at shivas. I go to a lot of shivas. And I'm always listening to the stories because it's informative for what I do. So I was at Shiva. He was an unbelievable man, unbelievable life. He lived till 67. He was a child polio survivor. He was a child cancer survivor. A whole slew of things. They told me he had 40 operations in his lifetime. He survives to 67, raises a family, 4 kids, Latiferet, and then has cancer again. And they know already he's terminally ill. And there's some urgent event. They bring him to the hospital. They say, should we resuscitate him or not? 40 surgeries in his life. All the kids look at each other and said, I don't know, what would he have wanted? Who's making this decision? They turned to his spouse. I don't know. I didn't talk to him about it. Now, I'm not blaming anyone because he was such a positive person. That's what allowed him to live through 40 surgeries. But no one had thought about beforehand. In the end, they did CPR on him for a while, broke his ribs, and he died. That is not a way this person should have died. And I'm not trying to give this as a dramatic example, but try to raise the point that there's certain basic conversations which are so important to have. And if we have these conversations, right, we can be much more informed about it. Now, of course, you need to know halacha, you need to know some of the framework for these types of things. But this is doable today. And if we're willing to confront and talk about these things, we'll be in a much better place. So I hope and pray that this document will be useful for a lot of people. But honestly, it's not about my organization's document or anyone else, right? We should just get this going in our community as a whole. And if it's someone else's document that works, that's great. Right? There are many different models for this. In Israel, the law is that the document has to be reviewed every 5 years, right? There's the proxy, it's only 5 year, which has a lot of logic to it. The American lawyers don't like it. The American lawyers don't like it because they say that you want to keep this as a stable document and not keep on having to question documents one form or another. Because then you put into the old documents into question. You could argue back and forth on this. So we advise people that every 5 years, you should make sure that this is up to date for what you want without throwing it into question. That's sort of like a little bit of the compromise in terms of our legal advisors. So I hope that this will be a helpful thing. It's not gone out yet on the web, and I would very much welcome feedback. So I know it's not necessarily the most pleasant Shabbos reading, but nonetheless, right, if you want to take a look and give some feedback along the way, we'd certainly be happy. Go ahead.
Two quick things. One is,
Oh.
what if your rabbi is 90 years old?
So people ask me this all the time. They say to me, I'm not going to name names, but they ask me, my rabbi's 90 years old, should I put him down? Well, it depends how old you are. Right? So if you're 96, okay. But if your rabbi's 90, I wouldn't name him unless you're willing to keep on updating this document, which is fine. I get this question all the time because there's certain poskim that people have in mind. And I also say to them, by the way, he's a great posek. I try to talk to him as much as I can, but just know he's busy 18 hours of the day, giving shirim and this or that. So you might want to have someone who's more accessible, right, and whatnot. But that's part of the question.
Does the rabbi have to live in the...
No.
I'm in Canada.
No.
And the rabbi be in Israel.
Rabbi can be in Israel, Rabbi can be in Australia, because again, it's not a legal designation. You're telling the legal proxy, this is the person I'd prefer you to talk to. If you can reach that person in other countries, goes on to head.
So my last question is a naive question. That is, what if I've never thought of this before? I have no idea what I'm going to start thinking about. Where do you start?
So you start with a form that tries to teach you how to do this.
So I want to go back on the Toronto thing because it's not what I was thinking about.
Oh.
I wanted to make that clear to people in case they have. It goes back about 9 or 10 years ago, before COVID.
Yeah.
The Rabbi did put out something in Toronto, published it, and disseminated it through all the different shuls. Many people in this room and beyond have received that, and that was the document that it was. And the difference between that and the RCA document was that it was going back in time to really the cookie cutter of menu type of style.
Uh-huh.
And a lot of the people, so what you're showing now, I believe is brand new, this Chaim Aruchim from Toronto, which I'd like to know more about in terms of that. But that's just a comment. The question is, in the hematite, if you could distill it down to a few words, what is the real advantage of this over the newer RCA? In other words, the revised RCA.
I think for one thing is that there's a clear legal designation that's much clearer about who the proxy is, which I think is an important legal level. I think today the most important thing on a legal level is to buttress the status of the decision maker. Because what you want to protect yourself on is that you're protecting the proxy and saying, I think this proxy has my best interest in mind, knows what my wishes would be, And I'm declaring this and making this a statement, so if it comes to a court or comes to some disagreement, they're much more protected. I don't think the other documents are as good in terms of that. That's on the legal level. The second point, which I think is important, is we do give an option for organ donation, because it doesn't happen every day, but when it happens, lives can be saved. I think that's important. We should have that on the table. I mean, there's just a case in New York of a brain dead patient at the age of 92 who donated liver. So, it used to be, organ donations for young people. Now, I thought it was still like 70. They had a 92-year-old. It comes up. It can come up, right? And so I think it's important to put that on the table and to keep that conversation going on it. And the third part is the conversation guide. It's important to have conversations about this, to be at least about general sense of values and preferences, even if you're not going to make advanced decisions.
Why did you say that this is not yet applicable to Ontario?
Because the page here is a reference to some American laws about disclosure, HIPAA, and given the case law, you see, everyone's trying to anticipate what the law, what would happen if it goes to a court. So the Americans have a certain formulation that they think works, even though there's a lot of states in America, and that's what we're going with. And the Canadian attorneys that I'm working with are still trying to figure out what formulation they think is best. A lot has to do with the law in terms of, are we going to go with substitute judgment, best interest, when and how that will happen. And so that's what we're trying to.
And when that happens, that'll be on your website?
Yeah, for sure. We sent that everywhere. But the conversation guide is good now.
Great.
If you live in two different countries, like Israel and Canada, which we do,
Yeah.
do you have to have one there and one here?
I would. I'll tell you why. I mean, it's a little bit tricky, but you can be in a situation where you have a healthcare emergency somewhere else and you didn't have it. Now, it depends a little bit on what you're looking for. Like my grandmother, Zichron Levracha, it was terrible. She had a DNR set up. She was living in Manhattan and Lower East Side, and she came to visit my aunt in Toronto, and that's where she died. And when the ambulance showed up, they were resuscitating her. And my father was a distinguished bioethicist, is on the phone from Texas, screaming at the paramedics, can't do it. My cousin, who's a doctor in New York, is trying to figure out this or that, but the paramedics were doing what the law.
You have to interview, you know what your wife thinks about you or your spouse or
Right.
whatever you put down, and you know what your rabbi or you know what his decision making is and how he talks about certain things, but what is his training in this area? And you have to interview your...
I don't know if you have to interview your rabbi, but I think it's helpful to have a conversation with your rabbi and say, listen, we're trying to come up with, create this. We want to know, do you feel comfortable, for example, being named as our... Not every rabbi wants it. And some rabbis will say to you, listen, I'm your first call, but I'm going to send this up, which is fine. That's totally fine. Then you want to ask them, who are you sending it up to? Who's your posek on healthcare questions? That's a very important question. And depending on their answer, right, you might say, oh, that sounds great. It makes a lot of sense. That's respectful, this or that. It could be right, that this is a person who has different views that you feel strongly different than. And so I would tell your rabbi, listen, my general feeling on this is where I'd want to be, within the realm of halacha. And your rabbi, who I think will be honest with you, will say either I can work with that, or call a different rabbi.
Rabbi shopping.
No, I don't. It's not rabbi shopping. In general, what does that mean, rabbi shopping? You're not searching for a tailor. You're making a decision about who's your posek going to be on these questions. I mean, so there are plenty of people. They ask their Hilchot Shabbos questions to one rabbi, and Kashrus questions maybe the same person. When it comes to Hilchot Nida, though, they talk to someone else for a number of different reasons. That's perfectly reasonable. But you should figure out who that's going to be, and let your family members know who that's going to be, which is not going to be easy for all your family members. I don't mean you, right? Because you could have kids or this or that who have different rabbis who have different positions on this. B'vakasha, you should decide, unless you want your kids to decide for you, that's not bad, but let them know. Let them know what it is. Yeah, last question.
Do you have to discuss with the person you decide to have as your posek? I mean, we go to these lectures, okay?
Yeah.
We go to these shiurim, and maybe I'd say, I want Rabbi so-and-so to be my posek about these issues.
Yeah.
But he doesn't really know me, but I've read and studied a lot of the things that
Yeah.
he said, and maybe I feel like that's the person that's in line with what my thinking is. So do you have to like sit down and have this talk with a rabbi?
I would, because think about it. Let's say you put him down, put his phone number down, and he gets this phone call, and he says, Rachel's in the hospital and wants to know anything. Who's Rachel? And also, many poskim, particularly if in a certain realm of psak, right? Not everyone, but many poskim are going to care, at least to some level, of what your general values and preferences are. So if you sit down with them and you call them up and say, listen, or even send them this document, the guide, and say, listen, would this help you get a feel for who I am? And talk to them. So again, they're not going to be able to tell you, I'm going to tell you X, Y, and Z in given scenario. At least they'll know something about it. But I always, in general, encourage people, Matai has a hotline. Right? You can put us down as your backup, or if you don't have a rabbi, he's in primary, right? You can call us and we'll help you. But I always recommend to people, it's best to do it with a rabbi who you know, and they know you, and you trust them. Because these issues aren't just technical halachic questions. Is a chicken kosher or not kosher? There's a lot going on about it, and I would want a rabbi for some pastoral help for you, for your family, and whatnot. So it's always better, right, to have someone that knows you and that you know them. But, I see this now all the time, particularly after COVID. People will stop going to this show, that show, whatever it might be. Someone called me up the other day, I'll end with this. He asked me about the document, whatever. So I said to him, you're a firm guy. He's 80. You're a firm guy. You've been going to shows since 80 years. You're a rabbi. So he said to me, I was very close with this rabbi. This rabbi died last year. But now I'm 80, and I got to figure out what to do. So what about your kids? So I know his kids. So one of his kids is a chashuva guy who goes to shul, and his rabbi just retired, moved to Israel, and has health issues. So now they need to figure out. But I'm happy they're trying to figure out who that call is going to be made to. Okay? Thank you.
We heard a little bit about the organ donations in general. Now we're going to focus on specifically the area of live organ donation. For this, of course, we're going to have Rabbi Steinberg, who's going to present the issues, the halachic issues. And then we also have with us today Rabbi Jaffet, who is the executive director of Renewal. Renewal is a project that is in the United States, and it has an office here in Toronto as well. And we're going to hear more about it specifically. So I would like to look at this as we're going to first learn the theory, and then if this is something that works for everybody, tachlis lamaisa, we'll see how this can actually be put into actual practice. Without further ado, Rabbi Steinberg.
We are talking about live organ donation, which means that a person who is still alive can donate organs, tissues that can save lives. This is obviously limited as compared to cadaveric organ donations, which one can donate almost all organs, all tissues. Here we are limited with some organs and tissues only. And I'll just give a brief overview on the medical aspects of the donations, and then we'll discuss a little bit the halachic parts of it. So if we talk about a kidney donation, as we all know, usually every healthy person is born with 2 kidneys. Turns out that we can function very well with 1 kidney, so we have a spare kidney, and if someone lost his kidneys because of disease or because operations or whatever, and he can't live without kidneys, there is an option that each of us can give one of his kidneys to someone who has none. Both will have 1 kidney, and both can live very well. So there are other options for people who are in renal failure, who don't have kidneys that function. One is dialysis, and the other one is cadaveric donation. Turns out that live organ donation is preferable, medically speaking, to the other 2 options. Certainly over dialysis, which has a lot of complications, quality of life is much reduced, and certainly kidney donation is much preferable. But even if we compare cadaveric and live kidneys, the live kidney has longer longevity than cadaveric. From the donor's point of view, immediate mortality due to the operation, maybe the numbers are even lower nowadays, but certainly it's minuscule. I always say that, at least in Israel, driving a car has a much higher percentage of mortality than kidney donation, and yet no one thinks twice and he drives. So from this point of view, no one has to think twice to donate his kidney. There are some complications due to the operation which are transient, temporary, usually takes about a month and the person recovers totally and he goes back to his life. There are probably no late complications, although there are some studies that show that after 20, 30 years, blood pressure is a little higher, but one has to take into account the age, because after 20, 30 years, anyway, the person becomes older, and it's not clear whether this change in blood pressure is due to the one kidney or due to age, but even then, it's not something that really causes medical problems. And there is almost zero regrets from donors. Even if they donated the kidney and it didn't take, or the person died earlier, or it was someone who was sick to begin with, and it didn't really help him, people who do it usually wholeheartedly, and whatever happens, happens, and therefore it is almost zero regrets. If we are talking about bone marrow donation, that obviously can be an immediate life-saving procedure. People who have malignancies, leukemias, and other people who have bone marrow suppression, or after treatments that cause bone marrow suppression. There is no risk to the donor. It is replaceable, renewed, and there's some pain and discomfort for a short while, and usually it goes away, so it's a real mitzvah without any risk. It is a little different when we talk about liver or lung donation. I'm talking about live liver or lung donation. What is being done is we have 5 lobes of lungs, so one lobe can be taken out without really causing any difficulties to the donor. Usually it goes to a child where this amount of lung tissue is sufficient. And when we talk about liver, part of the liver is cut off from the donor and given to someone who is in liver failure. Both are growing and usually almost totally replaceable, and therefore there's no problem with losing part of the lung or the liver. However, it is a major surgery in both cases. There is some mortality rate, and there's a longer morbidity, although the recovery, if everything goes well, is full. It is a little bit more dangerous and maybe has different halachic perspectives. Now, where can we get the organs? And let's focus on kidney, because that is the most frequently encountered organ that is being donated. So the most easy to understand is genetically family related, such as a parent, an offspring, or a sibling. They are part of a family, emotionally, physically, genetically. That makes a lot of sense. There can be also a non-genetically family related, such as a spouse. There are 2 different people coming genetically from 2 different families, yet they live together and they care for each other, so that also makes sense. There can be a situation of non-family at all, certainly not genetically, but emotionally related, such as a friend, a good friend. They were together in the army or in the yeshiva or in the university, they know each other, and here one of them needs a kidney, the other one has a spare kidney, he can donate it. There can be also cross-donation, which is a situation where a spouse is willing to donate in his family and another spouse in his family, but they don't match. So they cross-match, and the husband of woman A is a match for woman B, and the husband of woman B is a match for woman A, and then both can cross-donate, and that also makes sense that people would like to do it. And then there's a whole host, much more frequent in numbers, which is totally altruistic, without any relations, without even knowing each another. They are not friends, they don't know each other. Someone comes and says, I have 2 kidneys, I want to do something good in my life, I want to donate a kidney, and whoever it goes to is fine with me. At some point in the past, I headed the committee from the National Authority for Organ Transplants, the Committee for Live Organ Donation, and a young woman comes before us and says she wants to donate to whoever is in need. She doesn't care who. She wants to donate. I asked her, what's your profession? So she brings food by motorcycle. She distributes this food. That's her job. And she is single, and she has no family, and she doesn't care specifically for anyone. She wants to do it. When I asked her, why do you want to do it? She said, my life is a boring life. I don't do anything good for society, and I can't do something ongoing good, let's say take care of an older person or give tzedakah. That's not my nature. I want to do once in my life something which is very good. I'll know that I'm worth living here in this world because I did once such a good thing. So these are ideas that people have to become altruistic. Now there are other sources, some that have no relations, but they do it for compensation. They want an income. Certain countries don't allow it, other countries allow, but they won't be compensated, but it can be done in a controlled fashion, and I'll speak about it in a few minutes. The other options are certainly immoral, illegal, and shouldn't be done, and that is organ trading, trafficking, where agents are approaching poor people and promising them a set of TV or a trip to somewhere, and they take their kidneys. Sometimes it's done even by coercion in a criminal way, such as the story was that it was done in China. People who were waiting for execution, the family was promised money for burial because the person is anyway executed, so let's execute him in a way that we can take his organs at the same time. So those are obviously illegal, immoral ways. There is an issue that, if time permits, we'll discuss. If the only person who is suitable medically to be an organ donor, whether a kidney or bone marrow, doesn't matter, but he is a minor or he is incompetent, he's mentally retarded, and he can't give consent to be the donor, and yet he is the only one that can save life. Should we take it from him or not? So these are some of the sources that may cause difficulties. Now, if we come to compensation, in most countries, most Western countries, compensation is not permissible. In Israel, it is permissible to compensate for expenses. They call it expenses, but it is a fixed sum. Sometimes it's much less than the real expenses. Sometimes maybe it doesn't even cover the expenses. A fixed sum, it's called compensation for expenses, and that's permissible. But to compensate really for the altruistic donation is not permissible. It's illegal in Israel, and I assume in Canada as well, certainly in the United States. and in Europe, they are very strict about it. So how can you, if you want to compensate, how can you compensate someone who is doing such a good deed? One way is to pay directly cash money. You are willing to donate. The kidney is worth $300,000. Here's a check for $300,000. You are saving a person, and you are getting paid for the good deed that you do. There can be also, and that is done by the recipient, direct connection between the recipient and the donor. There can be a cash money payment, but not by the recipient, in order to avoid pressure that sometimes may be beyond what the donor would have liked, but it can be by a public fund. Let's say the government allocates an amount of money. Everyone equally gets the same amount if he donates a kidney or bone marrow or liver. And it's done by the government without direct relationship between the recipient and the donor. And that can be divided into two parts. One is that we can call it a reimbursement, is a significant amount of money that people who are in need of money will donate their kidney, not because it's a good deed, but because they want to make money. Or it can be a sum that most people wouldn't do it because of the money, but once they do it, they're happy to get some compensation. There is also an option to do indirect payment, not giving cash money, but let's say a reduction in taxes or in mortgage or paying for health insurance or for education of the children. There are many ways to compensate a person who did something good. Another form of compensation, which is legal in Israel, is to prioritize. If I am donating a kidney, I'll have a priority when I'll be in need of a kidney, skipping the waiting list, and not only I, but also my family. So that if I donated a kidney, a member of my family, depending if it's first-degree family or even further, will get points to skip and be ahead, and that in Israel is organized and allowed. All the rest are not allowed. So the moral standpoint of most Western societies is that organ donation should be absolutely altruistic, no compensation of any kind. We'll come back to it in a minute if it's really the right way to look at it. Now, what are the halachic issues related to live organ donation? I'm not talking about cadaveric organ donation. There, the halachic issues are very different. So it is permissible halachically, provided the donor and the recipient fulfill certain basic requirements. On the donor side, it must be something that has no significant, thank you, that has no significant risk to the donor, and I'll come back to it why this is required. There should be no significant complications and no need for long-term treatments or medical follow-up. In other words, the risk that the donor is taking is either zero or at least minimal. If it is more than minimal, and we'll discuss what it means, then the donor is not allowed to donate. On the recipient side, there has to be good success chance, otherwise why take out an organ from the donor? And that is the best and the only way to save the life of the recipient. If there are other ways that we can save his life, we wouldn't ask someone to donate. Now, what are the considerations? Against live organ donations could be the prohibition against self-damage, chovel ba'atzmo, when I am willing to give my kidney, I am undergoing damage to myself. And there is a prohibition to cause myself damage. There is also a prohibition to take risks. I am healthy. I don't need to undergo this procedure. I'm not doing it for my medical needs. I'm doing it for someone else. If I am healthy, I can't take a risk even in order to save someone else, or I can. That's the issue. There's a philosophical question, I won't go into it, if we are at all honest on our body to consent to do it. Who are we to say that we are willing to damage our body because we own our body? Probably we don't own the body. So who are you to give a consent? But that's more a philosophical question. On the other side of the coin, there is an obligation that is called Hashavat Aveidah. The same way as there's an obligation to return a lost object. If I find on the street a purse that has a significant sign, and I ask who lost the purse, and he gives me the right signs, I have to return him, and that is called Hashavat Aveidah. That's a mitzvah d'oraita. Says the Gemara that Hashavat Aveidah is not only an object, but also one's own body. If you can return the body to health, that is also called Hashavat Aveidah. And if this person has no kidneys, and I am able to return him his health, I'm fulfilling the obligation of Hashavat Aveidah. There's also an obligation, Lo ta'amod al dam re'echa. If you see that your fellow man is in danger, you must do whatever is needed to save him from the danger. And if I see someone who has no kidneys, certainly he's in danger. If the way to help him is by donating an organ, so I'm fulfilling Lo ta'amod al dam re'echa. And the general V'ahavta l'reacha kamocha, the same way as I would like, if I don't have a kidney, that someone would save my life by giving me a kidney, I ought to do the same to my fellow men. So if we come back to Isur Chavala, if it would be a prohibition, then we can't donate a kidney because there is certainly a Chavala. So in the Gemara, there is a dispute if the Isur Lo Tachvol is only someone else, but if I'm doing the Chavol to myself, there is no prohibition, or Lo Tachvol means not only the other one, but also myself. That's a machloikes. But the Halacha, the Rambam, and Shulchan Aruch all paskin that there is no difference, and the Isur to damage is both someone else and myself. So there's an Isur to cause myself damage. Although the Shulchan Aruch says that there is an Isur, but there is no punishment on it. The punishment is only if I do a Chavala, if I do a damage to someone else, but if I do it to myself, I am exempt from punishment. But that doesn't mean that it's permissible. So Chavala is atzmi, myself, is less than doing it to someone else, but it is still an Isur. But the Rambam, interestingly, writes, לא החובל בלבד, אלא כל המכה אדם כשר מישראל, בין קטן, בין גדול, בין איש, בין אישה, דרך ניציון או ביזיון, הרי זה עובר בלא תעשה. Now the definition of Kabbalah by biblical standards is something that causes a blood to come out. That is a Chavala. If I just hit someone and blood doesn't come out, then that is not a definition of Chavala. Yet there is an Isur even to hit someone without blood coming out. But certainly when we take out a kidney from a donor, there is blood that comes out. So it's a defined Chavala. But says the Rambam, when is the Isur of Chavala? Only if it was done, and there are two gerses in the Rambam, only if it was done derech nitzayon, meaning by fighting with each other, or derech bizayon in a degrading, humiliating way. So that if I hit someone, but it wasn't during a fight between us, and it wasn't to humiliate him, then there's no issue. For instance, a teacher in those days hit his pupils all the time. And there was not Isur Chavola because he didn't do it as a fighting process, and he didn't do it to humiliate. He did it for education or whatever a good reason he had. So certainly, donating a kidney, although it is a chovel be'atzmo, it is not done by fighting, and it is not done in a humiliating way, and therefore it's like any other medical procedure that always, surgical procedure that always has chavala, but it's not done in these two fashions, and therefore that is permissible. Another heter is that all the isurim ben adam lechavero, if I hit someone, or if I steal from someone, or if I do some damage to someone, it is only prohibited if it is done in a way of destroying without any good purpose. So wherever there is a good purpose to what I do, there is no issue. And since giving the kidney is a good purpose, there is no issue chovel in this fashion. And certainly, according to those poskim that say that for a mitzvah you're allowed to, let's say you build a sukkah, and while you build it, you got a cut or you got a splinter or there is a chavala on yourself, that is not an issue because you did it for the purpose of fulfilling a mitzvah. So from the din chovel, it is okay to donate. Now, as far as what? I skipped one. Right. Okay. Now, as far as taking risk to save others, so that is called מכניס עצמו לספק סכנה כדי להציל חברו מוודאי סכנה. Am I permitted to put myself in a doubtful danger, even in order to save someone from a certain danger? So that is discussed in the Yerushalmi, and according to the Yerushalmi, it is permissible to put oneself in a doubtful, dangerous situation in order to save someone from a certain risk. But apparently, according to the Bavli disagrees with the Yerushalmi. There's a whole big discussion. I won't go into it. And most poskim hold that the halacha is that you're not allowed to put yourself in any danger, even if it's doubtful, even in order to save someone from a certain danger. So if I'm willing to give my kidney to someone who is in a vadai danger, the person who has no kidneys is a vadai danger, but I am risking myself maybe in a doubtful way, according to the halacha and the Bavli, I'm not allowed to do it. So how can I be a live donor in such situations? So the answer to this is that there is a famous tshuva by the Radbaz, and the Radbaz describes a situation. I maintain that it never happened. He had an answer, so he created a question in order to give the answer. There is a famous book called Trumat Hadeshen, which was the source of the Remo from the Ashkenazi Minhagim, that the whole book is built on this premise, that he invented questions so that he could give his answers. That was a method of teaching. But even if it was a real, so what was the situation? That some ruler came to a Jew and he said, tomorrow morning I'm going to kill your neighbor Jew. I'm willing not to do it if you will allow me to sever your arm. I'll cut off your arm and then I won't kill the other person. So the Radbaz was asked, really or supposedly, can the neighbor Jew allow to cause him such a serious chavala in order to save from vaday sakana the other Jew? Because if he won't agree, the other Jew will be killed. That was the shaila. And the answer of the Radbaz, I won't go over the whole tshuva, is that if there is a real danger to the rescuer, and he is willing to take the risk as if midat chasidut, he wants to be better than required, he calls it chasidut shel shtut. He is a shoite. He is just causing himself a serious danger where he is not obligated to do it, even if he's going to save someone else. The problem with this responsum, and everyone brings it as a guideline, when are you allowed to put yourself in a risk in order to save someone else? The problem is that they didn't know statistics. And what does it mean, a significant risk that you are doing chasidut shel shtut, as opposed to a non-significant risk where it is midat chasidut, which is okay to do. Now the Gemara on the posuk lo ta'amod al dam re'echa, the Gemara in Sanhedrin, gives 3 examples. What does it mean lo ta'amod al dam re'echa? One is that a beast is running after your friend, that you are obligated to kill the beast in order to save the life of your friend. The other one is that a robber is running after him and wants to steal from him, and he might kill him, so you have to intervene. And the third one is that you see someone drowning in the river, so you have to jump and take him out. All 3 examples are an obligation of lo ta'amod al dam re'echa, because if you won't do it, each of the 3 will die. But you are taking risks. Even if you are Shimshon HaGibor and you know how to fight with a beast or with a robber, there is still a sakona, a sofek sakona. Even if you are the best swimmer, if someone is drowning and you are jumping, who knows, you may also drown. So we see that if the risk is very small, not only isn't it prohibited, it's actually the mitzvah of lo ta'amod al dam re'echa, according to the examples of the Gemara. So how is it different from the case of the Radbaz? And the answer is that these 3 are very minimal risk for people who can do it, whereas this is a significant risk. But how many percentages is a minimal risk, a Beinoni risk, a big risk? We don't know. Now, most of the poskim currently, by the way, Rav Ovadia Yosef holds that to donate a live kidney, a live donor for a kidney is an obligation, is lo ta'amod al dam re'echa, because he says, and it seems very logic, that the risk of giving a kidney, a live kidney, is equal or less to the 3 examples that the Gemara gives. And if the Gemara calls it lo ta'amod al dam re'echa, so donating a kidney should be a biblical obligation, shel lo ta'amod al dam re'echa. Most poskim, however, hold that if there is any risk, there is no obligation. It is a midat chasidut, you're doing a good deed, but it's not an obligation. Lo ta'amod al dam re'echa, according to most poskim, is that you have to bother in order to save. Let's say you're driving and you see someone on the road that is injured, you have to stop, you have to call an ambulance, you have to see if you can help him, but not to risk yourself at all. That is according to most poskim. And therefore, most poskim today hold that it is not chavala if I am a donor of an organ, and it is midat chasidut to do it, but it's not an obligation. That's why, I don't know if anyone here donated a kidney, but most people don't donate kidneys, and they are not violating lo ta'amod al dam re'echa because it's only midat chasidut, and not everyone is obligated to do midat chasidut. So where we stand now is that blood and blood products is obligated because there's no risk. So that is lo ta'amod al dam re'echa. If you match someone who needs bone marrow and he's going to die unless he gets the bone marrow that you are a match for, if you don't give it, it's lo ta'amod al dam re'echa. And you are not risking anything. So therefore, that is an obligation. But a kidney, as we just finished the discussion, according to most poskim, is only a noble deed. Liver and lung is already a higher risk, and therefore, probably it is usually not permissible unless there is a very strong call to do it. Now, if we come back to the compensation issue, the halacha is ma ani bechinam af atem bechinam. The same way as Moshe Rabbeinu received the Torah for no compensation at all, so we are obligated to fulfill all the mitzvahs and not be compensated. But imagine who will be a rov of a community, a teacher in a school, a dayan in a court. All these people get salaries, and some of them get nice salaries, right? They are teaching Torah, they are ruling, they are judges, which is a mitzvah, and they should do it for no money. How come they are getting paid? I am a physician, I'm being paid quite nicely, and I'm doing a mitzvah of saving life. How can I get a salary? The answer is, et la'asot la'Hashem heferu toratecha. If the condition is such that if I'll be strict with fulfilling the mitzvah, there will be no Torah, then I'm allowed to violate Torah. Heferu toratecha. So you won't find enough people to be teachers and rabbis and rosh yeshivas and ramim and so on unless you pay them. So if you decide to go strictly with the law that you can't pay them, you will lose much more than just violating this principle. And the same with a physician, with a fireman, with a policeman. All are doing mitzvahs. They should have been doing it for free, and yet all are compensated. So the question is, why is this exception for live organ donors? That's the only good deed that society requires people to do for no compensation. Why is it different than any other good deed that people do? There are officers in the army that risk their life, they get a higher salary for it. There are physicians, there are nurses, there are many people who are doing good deeds, and no one expects them to do it for no money. Why should such a donor do it only altruistically without any money? So the official reason is that if a live donor would be compensated, then only the poor will become organ donors, and the rich will be the recipients because they don't need the money, so they don't need to ask for donation to be donors. The poor want to make a little money, so they'll become organ donors. But the question is, if this is the situation and we are not compensating, are the poor less poor? Are the rich less rich? Did we change anything in society by the fact that we didn't pay the poor for organ donation? It doesn't change anything. Whoever is poor, and whoever is rich is rich. The fact that you compensate doesn't really make them less poor or more poor. On the contrary, if they are poor and they are doing something good, help them not to be so poor. What's wrong with it? Obviously, if the compensation will be so high that even a person who would never in his life be willing to be a donor, but for so much money he would do it, then the consent is not a real consent. But we're not talking about such monies. We are talking about reasonable compensation like any other person who is doing a good deed. I don't understand why ethically it should be a problem. But what was found when it was done illegally, let's say in India or in or in China or in such places, that they came to people, they said, be an organ donor and we'll give you $1,000. So such a poor person says, why not? Takes $1,000, gives the kidney, buys a TV or a little car or something, wastes the money, and then he's left without money and without a kidney. So that is really not socially a good thing to do. Therefore, I propose to the Ministry of Health that there should be no relationship between a recipient and a donor, so that there will be no pressure, I'll pay you under the table more, or whatever. It should come from a fund of the government, and it shouldn't be cash money. It should be a compensation that is worthwhile to the donor in a reasonable way, and he did a good deed, and he's being compensated. For instance, he'll get a few points in his taxes to pay a little less, or he will get points for education of his children, or for health insurance. This is very worthwhile. It is a nice assess of the society that thinks that they did a good deed, and it doesn't reduce from the importance of the good deed that he did. Why should this be the only exception of a good deed that should never be compensated? In fact, halachically, all poskim agreed that it can be compensated. It's the same eferu toratecha like being a ram or a yeshiva or a physician. It doesn't matter. We shouldn't do it. We should do it for free. But since we are not doing it for free, that is not different than any other good deed that people are doing. And therefore, I really don't see a good reason why not compensating. So these are some of the issues related to live organ. The renewal group is doing a terrific job in North America. We have in Israel an equivalent group called Matnat Chaim. And I voluntarily, I don't take money, I serve as the head of the ethics committee of Matnat Chaim. And there are ethical questions that come up with the good deed of people who are altruistically donating organs. There are questions of priority, of the recipients, who gets first. There's a list. Can you skip the list? Can you choose someone or actually not choose someone on the list? Especially has to do, it's a delicate situation when Arabs are high up on the list and someone says, I'm willing to donate a kidney, but not to an Arab. So you have to skip him. So it's a major problem, legal, but we solved it in several ways. The question of who is the recipient without disclosing the name, because that's only if the recipient wants. Sometimes they want to meet. But for instance, he can be a rapist, a murderer, and no one wants to donate to him. So I want to know, who am I going to give it? Does he have a clear bill of behavior? Is it a terrorist? And there are many such issues that we are dealing with on an ethical format, but at the moment, in Israel, Matnat Chaim reached 1,300 donors, live organ donors. Some couples, both the husband and the wife, donated their kidneys, and now it is the major source of kidney donation, much more than cadaveric kidneys, that are now less than live organ donors. That really took well, and I'm sure we can hear from Renewal what the situation is in North America. Thank you.
The Gemara's conflict between Yerushalmi and the Bavli. Does anyone try to explain it that the reason Reish Lakish would go is because he was a trained gladiator and therefore he was an exception to the rule, since he could confidently walk in? Otherwise, how do you explain a fireman running into a building if he's not sure if somebody's there?
Right. So you're right that Reish Lakish was listim. He was a strong person. he knew how to fight, but this didn't come up by any of the poskim as a reason why the Yerushalmi justified Resh Lakish. It seems like the Yerushalmi justified it because that's the true act. Now, the Bavli doesn't talk about it specifically. So it's not clear if the Bavli disagrees or he just didn't discuss it. But the fact that the Bavli didn't discuss and Resh Lakish was known to the Bavli, seems like the Bavli disagreed. That's the feeling of the poskim. But you're right that Resh Lakish is not an incidental name in such a situation, but it's not brought up as a reason.
With respect to the compensation, a number of countries that do allow certain forms of compensation, but also with a number of other areas, including plastination of bodies and a variety of other things, the real ethical problem arises because once you allow it, you create an international market for organs, or in the case of plastinated bodies. And what we've seen with that is even if it's very regulated, you still end up with many people who are either killed or organs harvested in a variety of ways, or real social pressure. So it's not necessarily a problem within Israel itself, but as soon as you allow it anywhere, we've seen these kinds of things really. The international market, once it's created, it goes off the rails.
But that's exactly the point. Even today, when it is not allowed to compensate, there is a trading. We know. So I don't think logically that if you allow compensation the way I suggested, not to pay money, that will not increase the trade because someone in a different country won't get tax deductible there. He will get it only here. So you can really create a compensation system that will not be different than the situation now with these faulty acts where it is not permissible. I don't see that this will make a difference.
Thank you, Rabbi, for your talk. Also, in case of Vadai Sakana, we had a few years ago an officer who jumped over a grenade to save the life of many others and save his soldiers. Yonah Navi said, Sauni v'atiluni el hayam. He said, threw me to the ocean in the storm, so to save the boat.
Right.
So we do have that situation of someone who was willing to give his life, literally, to save others.
Right. So certainly there's no such obligation.
Yeah.
In other words, if Roy Klein would have asked us, should I jump on the grenade to save others, we would have said no.
Yeah.
He did it because he thought that was a good deed, and obviously he is to be praised for.
But according to Rabbi, the Hasid Shoteh. Is that the case?
Yeah, but probably halachically, if you talk, it's a very nice deed, and it's hard to say to blame. But halachically, it wasn't the right thing to do. He's not allowed to kill himself. There's only one exception, and that is Sheva ben Bichri. If there's a person who is going to be killed anyway because he did something wrong, and he is willing to give up himself in order to save others, because he is anyway going to be killed if he is caught, then it's permissible. That's the story of Sheva ben Bichri. But anyone else, including Yonah Navi, that says, kill me in order for you to be saved, that is problematic, purely halachically speaking.
Okay, first of all, it was a great talk. You mentioned that minors and children, let's say with Downs, can't donate, but what if you do have a child that's a perfect bone marrow match, and let's say it's an infant? In fact, you probably heard the case about a child who did need a match, and none of the kids were a match, and they couldn't find a match, so then they had another child. And as soon as that baby was old enough to donate, the baby did so. And that of course did save the child. I shouldn't say of course, but it did save the sibling's life, and they remained extremely close and had a special bond. But that sounds like that wouldn't have been permitted in halacha.
No, right. So first of all, there's a distinction between an act that endangers the minor and an act that doesn't endanger. Bone marrow donation is not endangering the donor. So it's only the formal consent, yes or no. So if you talk about formality and you know that you can save life, then you forgo the formality. That is acceptable halachically. We are talking about a donation that may endanger the donor, either now or later. Here, you need a real consent. And if it is a minor or mentally retarded, he can't give a consent. There was a case, a very tragic case, where a father in renal failure took care of a son who was already old by age, but he was very mentally retarded, and he couldn't give a consent, and he was a match for a kidney to his father, and the father requested to take his kidney to save his own life, and he said, it is not only for my benefit, it's for his benefit, because if I'll die, no one will take care of him. If I'll stay alive, he will stay alive. So it's for his benefit. And yet the Supreme Court ruled against it, because that is a way that the consent doesn't exist, and in this case, if it may harm, you can't do it. The judge that ruled this ruling was Menachem Elon, who was a big Talmid Chochem on his own, and he discussed with me a little bit the pros and cons on that, and he finally decided to rule against. After a while, the father died because there was no kidney to match, and after a very short time, the son died as well. No one could take care of him, and I don't know if he ran into the street or something, and he was killed. And he called me up, Judge Elon, and he said, I regret my psak, because really the fact that this child could have been saved together with his father, and we couldn't foresee what will happen, but it could have been foreseen, I would have ruled differently if I would know it. So I think that there is a side to say that even if there's not full consent, if it's a minor risk, it may be allowed. Yet many of the poskim say that for a kidney you need a real consent. You can't do it unless you have a consent. Maybe in exceptional situations where there's no other match and you can't look for it. Nowadays, with such altruism like renewal and matnat chaim, probably a kidney can be found and not take it from a disabled person.
I'm going to ask Rabbi Jaffet to address us a little bit about the Renewal Organization. So once again, Rabbi Jaffet comes to us. He's the Executive Director of Renewal Canada. And Rabbi Jaffet.
Thank you very much. First of all, big thank you to Rabbi Professor Steinberg. It's an honor to share a microphone with you, and thank you for your Torah insights. Thank you to Rabbi Kellerman and to Dr. Friedman for inviting me here to speak with you tonight. And thank you to all of you, or this afternoon, for being here. I really do appreciate it. When Laser asked me to speak, I don't remember if he said 45 minutes or 4 to 5 minutes. But I figure Safek Durban Lahakel, we'll err on the side of caution, we'll keep it short, and we'll be open to questions afterwards. My name is Jonathan Jaffet. I have the honor of being the Executive Director of Renewal of Life Canada. By a show of hands, who here is familiar with Renewal of Life, what we do before? Fantastic. Most people. Excellent, excellent. So for those who aren't familiar, what we do is we help Jews who are in end-stage renal failure find altruistic kidney donors, save their lives. When I was 12 years old, my own father was diagnosed with polycystic kidney disease, and for about 7 years I saw him suffer on dialysis and eventually succumb to his illness. I was in university at the time. I was studying human biology and planned to be a good Jewish doctor, but I disappointed everyone and became a rabbi instead. When my family and I were living in Eretz Yisrael, studying Kolal, my wife showed me a little advertisement in one of the weekly circulars. It was about 1 centimeter tall by 2 centimeters wide, and said, "Mother of 5 needs a kidney, call this number." And she said, "Do it." I said, "Okay." So I called, started going through the process. It's a bit of a hassle, especially if you don't have a car, schlepping all over Israel. And eventually, it was turned out that I did not match her, but we came back to Canada, and I found out that a good friend of mine, Shlomo Anhang, had donated his kidney here through Renewal. Now, Renewal at the time only existed in America, and so he had to go over there to do a donation. It was very difficult and taxing, and obviously there's a lot of liability that came with that. So he started Renewal of Life in Canada to help facilitate the donations for people here, to make it a lot easier. In 2019, I was matched with a fellow in the community who needed a kidney. And then COVID happened. The Ontario hospital system shut down all kidney transplants. They said it was not apparently a necessary surgery. And Bezrat Hashem will be donating soon. Still waiting for them to kind of get back up and running. Renal USA has done almost 1,000 transplants right now. They started in the early 2000s. And like I said, Renal Canada was started really so that the Jews in Montreal and Toronto and everywhere else in Canada would be able to navigate the system here without having to go across the border. Essentially what we do is three services completely free of charge. The first is Shadchanut. We run a general kidney drive in the Toronto community, in the Montreal community. We try to find people who want to generally donate their kidneys. Baruch Hashem, we did this a few weeks ago during Parshas Kedoshim. As we discussed, the pasuk says, "Lo samin lo dam re'echa." We had 18 rabbanim, different shuls across the city, talk about what we do and the importance of kidney donation. And we had about 4 dozen community members come out to sign up, to become donors, to swap, see if they could find matches. The other thing we do within that is we help individuals specifically tap into their own communities. So if someone comes to us and says, I need a kidney, one of the things we do is we sit down, we create a social media campaign with them, we launch a website for them, we help them tap into their friends and family networks, we run live events in their synagogues, their offices, anything we can do to help them find a donor. What makes Renewal really unique is that we have our own dedicated lab testing facilities, so we can do cheek swabs and receive back blood types and HLA data, and we have a newly updated computer system now that helps us recommend the very best shidduch for every patient. So that's the main thing that we do. The other thing we do is we have a patient donor coordinator, and so we help the kidney patients and the donors navigate the medical system. It's not easy here in Canada. There's a lot of bureaucracy. In the States, the hospitals love working with Renewal because we basically bring them hundreds of thousands of dollars from their insurances. The hospitals here don't like us so much because they feel that we are this religious extremist organization, elitist, only helping our own, but that's the navigation part that we do. We also provide guidance and support throughout the whole journey because, as you can imagine, when someone is on dialysis and their body's failing, it can be very difficult, and someone who's just coming out to donate doesn't really know what they're doing, they need help as well. Thirdly, we raise funds to make sure that the heroic donors don't have to spend a penny on their transplants. So that means that we pay for their trips to and from the hospital. Sometimes that's a cab ride in the city of Toronto. Sometimes that's flying them from somewhere else. We provide care in the hospital for them as well. We take their families back and forth. We cater food for them. We provide babysitters. In one case, we actually had to take care of someone's dog for a while. You name it, any ancillary expenses, and of course compensation for time off work as well, so remuneration for lost salary. We do this a little bit in conjunction with the province of Ontario. There's a program here called Preload where they cover some of the costs and we make sure that all the other costs are covered as well. In general, we've been quite successful at finding kidney donors here in Canada, but there are exceptions. We had an amazing case recently of a woman whose PRA level was so high that only 1 in about 10,000 people would be able to match her antibodies. So we didn't find anyone here in Canada, and the hospital, UHN, figured she's never going to find anybody. But we opened up our database to the United States, and we found an American who matched her. It was an amazing thing. We flew him in multiple times for all the testing. We flew his family in. We got him a hotel stay. We took care of everything for him. And Baruch Hashem, it was a big success. Some of you might know him. He is the rabbi at Cedars-Sinai Hospital, Rabbi Dr. Jason Weiner. So he was here with us just a few months ago. Now, I want to tell you some of the kind of side benefits of kidney donation. Some people realize, some people don't realize, but it's good to kind of think about some of these things. So one is the spiritual, psychological rewards. I think we all know the Mishnah in Sanhedrin, Kol Makayim Nefesh Aches Mi'Yisrael, Ma'aleh Lov HaKosov, Kilu Kiyam Olam Maleh. Anyone who saves a Jewish life, it's considered as though he saved the entire world. And if you universalize that just a little bit further, just realize there's a kidney waiting list, right? So every time you take a person off that, every single person is getting bumped up one spot. Secondly, the donors get vetted extremely well by the medical teams here. I know for myself, went to doctor after doctor after doctor, checking every little tiny blood thing. We get an MRI, and they make sure that you are completely healthy before you do this. One of our donors-to-be actually went through this process and found out that she had cancer, and they saved her life. They took out the cancer, so they had this amazing check. So between that and I think the spiritual schusim, to be sure, probably explains why kidney donors have a statistically longer lifespan than average. Another side benefit, and this is something that Professor Steinberg alluded to, is that anyone who donates kidney is automatically bumped up to the top of the recipient list if they need one, and the renewal's policy is to extend that to their family as well. So I think of this as kind of kidney failure insurance for you and your loved ones. So for the medical professionals here, you don't need to explain dialysis and the struggles and the terrible toll it exacts on the patient's life and their family life, etc. But what I need from you is to spread the word. We need to encourage all Jewish patients to come to renewal if they need it. Tell your friends who are doctors about this. Tell your friends who are nephrologists or GPs, family doctors. Let everyone know what we are doing. Lastly, I'd like to remind you that literally everyone can donate. It doesn't matter how old you are or how healthy you are. Relatively healthy people between 18 and 75 can donate their kidneys, and other people can donate money. There's always something to do. Each transplant costs us about $18,000, and we never take a penny from the patients themselves to avoid any sort of ethical issues. Our dream at Renewal is to kind of flip the transplant waiting list on its head. Instead of having sick patients wait around to get a kidney, our vision is to have a long list of healthy donors who are waiting around to give someone else the gift of life. So please partner with us in our mission any way you can. Send us donors, send us recipients, and I'd be very happy to answer any questions. So, I mean, if they're coming to us, I mean, everyone on our list is Jewish. So we will give to a Jew. But we also have non-Jews who come to us for help, and we help them as well. So usually that means helping build them a website, social media campaign. We had one very recently for a non-Jewish fellow whose father-in-law happens to be the chazan of a reform shul over here. And we did a thing. We found a bunch of people who wanted to donate to him. So we help everybody. Yes? Who is a Jew? If we're not sure about that, we'll have to ask our local halachic authorities. We use the Psak Halacha of Rav Oilbaum in New York for all of our halachic questions. But as you can imagine, in general, it's someone who has a Jewish mother, who had a Jewish mother, who had a Jewish mother, etc. Or halachic conversion, of course. Any other questions?
Are there any statistics on a person who has been a donor that they then get some kind of kidney disease and need to be a recipient?
I can't really tell you the statistics, but I can tell you about different types of kidney diseases. So something like polycystic kidney disease is genetic. Donating a kidney is not going to stop you from doing that. And of course, you're extremely well vetted before you go through the process, right? Other times, kidney failure is because of cancer. So that cancer cannot happen. But as you probably know, most kidney failure is bilateral, happens on both sides. So it's not like you would have had one otherwise. The only time we really see one kidney failing is through trauma, through a car accident or a severe kickboxing accident. So we recommend anyone who donates not to go into professional combat sports afterwards. That's about it.
I would just think that, like, I've heard that as an objection. That, like, what if I need it? Kind of thing.
So then you can tell them that's not a worry. And if you need it, then you'll be bumped to the top of the list also. But yeah, it's usually bilateral. Whatever happens to one side happens to the other side. Go ahead.
Do you accept donors whose family members are already on the waiting list for a kidney?
Meaning?
Like, in other words, someone is incentivized because they know their kid is on the list already, or their brother's on the list, so they're going to donate.
Are you talking about financial donor or kidney donor?
No, kidney donor. So you say family members get bumped to the top of the list, so if they're already on the waiting list, will you accept your family members on the waiting list already? My daughter's on the list already.
To receive a kidney?
Can I donate my kidney and she'll get up the list?
Well, you could just donate to her directly.
What if she's not a match?
So if she's not a match, something we have here in Ontario is called the Paired Donation Program. And it's similar to what we saw before. The idea is that basically two people go to the hospital system. One says, I need a kidney, and one says, I want to donate a kidney. We're not a match. So they get put into this big pool of other people, and then it kind of becomes a chain reaction. So let's say it's a husband and wife. So husband A ends up donating to wife B, and husband B donates to wife C, and then husband C donates to wife A, that type of thing. We got to figure it out. And I think in Ontario they do it about 3 times a year. They kind of collect people. If you actually go in the paired donation program, it might speed things up. You don't always necessarily get the best match. They think it's the best match because then you have a larger pool. We actually have a larger pool of donors, though, within Renewal North America, and we also have much more advanced testing now, which is really cool. You had a question?
Does it not, I mean, it's less of an issue in Canada or perhaps Israel, but doesn't kidney donation impact your life insurance rates or medical
Not that I know if you're in Canada.
Well, here in Canada, I don't imagine it would, but
In America?
I don't know if somebody, like your partner organization in the US, that's something I would personally be concerned about, but it's a big issue.
I've never heard of it impacting, and like I said, I don't know why it would impact, just because it doesn't make you any more likely to die. In fact, statistically speaking, kidney donors live longer than average. So maybe they get a discount, I don't know.
When you have those paired donations, sounds like there would be a chance that one of them would back out. So are they done the same day, so there's no backing out?
Yeah, they're done basically all the same day. I mean, it depends how many there are exactly, but yeah, it's kind of back to back to back. It's a really cool process that the province of Ontario does. In general, though, the hospitals really want us to advocate for paired donation. What we've noticed is that it doesn't work so well for our community. Because usually what happens is Bob needs a kidney, and a bunch of people want to come donate to Bob, and so it's a direct donation. And I'm not sure if you know, but statistically, as long as you have the same blood type, odds are you'll be able to donate to the person. It's not like bone marrow, which is a very high level. Unless the individual's got a very high PRA level, they have a lot of antibodies, then it might be a problem, like in the case I mentioned with Dr. Weiner. But in general, it's really just kind of direct donation. And so that's what motivates people. Very few people will just come and say, hey, I want to give away one of my kidneys. Most people will come and say, hey, I want to give a kidney to my friend, my neighbor, my fellow Jew. Any other questions? Okay, thank you very much again. Please spread the word.
Thank you very much, Rabbi Jaffet. Really insightful. So that closes our program for today.